Hello, good evening, everyone. It's a great pleasure to welcome you all for this Lung Cancer Meet 2022. This is done under the aegis of Kaizen Hematology Oncology Network. It's a pleasure to welcome and invite our program director for today's webinar, Dr. Deepak Kupakta. He's a consultant medical oncologist at Care Super Specialty Hospital, Hyderabad. Hello, good evening, Dr. Deepak. We welcome you and we request you to start the proceedings for today. Over to you, sir.
Hi everybody. On behalf of Kaizen Hematology Oncology Network, I would like to invite all the delegates and the speakers for today's program. So we will be discussing extensively over the next 1.5 to 2 hours regarding various aspects of lung cancer, starting from mediastinal evaluation, management of small cell lung cancer, non-small cell lung cancer, early stages and advanced stages. Hope it will be a great academic feast, and we are having today an international speaker who will be joining us to discuss the role of consolidation immunotherapy in stage 3 lung cancer post chemoradiation. And we have several noted national speakers also who will be talking about various aspects of lung cancer today. So I would like to hand over the meeting from here to our chairperson today, Dr. Pavitran sir. Sir is a professor and head of the Department of Medical Oncology and Hematology at Amrita Institute of Medical Sciences, Kochi. He happened to be my examiner during my final year residency. So I would like to hand over the program to Dr. Pavitran sir.
Thank you, Deepak, for the kind introduction, and good evening to you all. So we'll start with the program because it is a tight-packed program lasting for about 3 hours. So without much ado, I will invite the first speaker, who is Dr. Dattatreya. He needs no introduction. He is a very good speaker, and he is the chief medical oncologist, Renova Soumya Hospital, Hyderabad. He will be talking on mediastinal evaluation of early stage lung cancer. Over to Dr. Dattatreya, please.
Thank you very much, Pavitra sir. It's been a long time we met in person.
Yes.
But I hope that these days are numbered now and we should all meet now. Let me start the ball rolling with the optimal staging of the mediastinum in early stage lung cancer, and why do we need to do that? Next slide. That's because it will help us in deciding the best treatment options for our patients of early stage lung cancer. And as you can see here, how what was previously labeled as a T2B lesion has now become T3, and what was previously a T3 has now become T4, and therefore the stage has been upstaged from stage 2B to stage 3 in each of these respective categories. So it becomes very, very important for us to know optimal staging is very important so that our patients get the most optimal treatment possible. And for that, we have various investigative tools. Next slide. Ranging from bronchoscopy to CT chest to a PET CT, EBUS endoscopic ultrasound, mediastinoscopy, and as we all know, stage 1B onwards, all patients of NSCLC should get an MRI brain with contrast done. And for small cell lung cancer histology, MRI brain is the part of the initial staging workup. Next slide. So let's look at CT chest with contrast versus PET CT for staging in stage 3 non-small cell lung cancer. Tarun, I had actually sent my PPT. Anyway, this is fine. So lymph nodes more than 10 mm along short axis predict malignancy once it's a CT chest. But yes, we all know that the sensitivity is 55% and specificity is low at 81%. It may help us in selecting appropriate procedures for tissue sampling by providing the images. Having said that, when you add PET to CT scan, then the sensitivity goes on to 80 to 90% and specificity is in excess of 85%. Next slide. So do we have some risk factors for occult N2? When we say occult N2, it means that it's not always detected by imaging, and based on all these tables here, some of the risk factors for having occult N2 are central tumors, size of the tumor is more than 3 centimeters, higher SUV on the PET, or suspected N1. All these 4 can be labeled as risk factors for occult N2. Next slide. So we go for mediastinal staging, less invasive on one hand, like endoscopic ultrasound, EBUS biopsy, to on the other hand, invasive mediastinal is conventional all the way to VATS. Next slide. So the recommended techniques for mediastinal staging are EBUS and endoscopic ultrasound. If clinical suspicion of N2 involvement remains high, even after negative EBUS or endoscopic ultrasound, then surgical staging with mediastinoscopy is recommended. So comes the question, when is invasive mediastinal staging indicated? And that's what my next slide will be. Next slide. If the tumor is centrally located, yes. Tumor size is more than 3 centimeters, yes. Or if the tumor has extensive infiltration of mediastinum with no evidence of extrathoracic disease or positive N1, even then that becomes an indication for invasive staging of the mediastinum. If on the CT scan it's bulky N2, then probably there's no need for an invasive confirmation. I'll again come back to that bulky N2 as well. Discrete N2, whatever may be the PET CT scan result, you should go in for an invasive mediastinal staging. On the CT scan, normal mediastinum. However, just a second. Yeah, on the CT scan, normal mediastinum, but positive on the PET, then yes. If the PET is negative, then probably it's not required. So these are all the indications of invasive mediastinal staging. Next slide. Now, this is the mediastinal staging algorithm protocol, which was published in Lung Cancer Research in 2021. And what they have tried to show is that if the PET CT scan report shows intrathoracic lung cancer with or without enlarged lymph nodes, and then if the PET scan shows that the mediastinal nodes are negative, and clinically it's N0, then you try to see if there is a low chance of unforeseen N2. And that means that it's not a central tumor. You're not suspecting N1. The T size is less than 3 centimeters, which are all the 4 points I mentioned before. So if that is the case, then you don't have to go any further. You can directly go for surgery or radical radiation therapy. But if it's clinically N1, or N0, but there is a high chance that you might be having unforeseen N2, despite a PET scan being negative mediastinal lymph nodes, then a tissue confirmation should be done by either EBUS or EUS. If the nodes come negative, you proceed to surgery or radical radiation. If the nodes come positive, the mediastinal nodes are positive, then you go in for multimodality treatment. If on the PET scan, mediastinal nodes are positive, then you see whether is it like a nodal mass or bulky lymph nodes. In that case, again, no tissue confirmation is required, and you go in, you jump on to directly multimodality management. But if it's not a mediastinal mass, but not bulky lymph nodes, then you have to go for tissue confirmation. If the nodes come positive, multimodal treatment. If the nodes are negative, you involve multiple faculties for evaluating surgical staging. And if the nodes come negative, then you go on to surgical and radical radiation therapy. So this is what is the staging algorithm protocol proposed by a team of people in lung cancer. Next slide. How do we assess the, now these are all, I mean, from EBUS onwards, all the way to VATS and TEMLA, how do you, which are all the lymph node stations each of these technique can access? Of course, it becomes easy to understand that depending on the lymph node stations, you would like to choose the process. Next slide. And the next slide. So mediastinal lymph node assessment can be taken as systemic lymph node dissection, systemic sampling, or lymph node sampling. Lymph node sampling means you only look at selected suspicious or representative lymph nodes and sample them. A systemic sampling means that you explore a standard set of lymph node stations. A systemic lymph node dissection means you remove all the lymph nodes which are bearing the tissue within defined landmarks for that standard set of lymph node stations. So this is what is mediastinal lymph node assessment. Next slide. Like I discussed the previous algorithm, the ACCP guidelines also are more or less the same, and this is one such schematic algorithm from them. Next slide. So let me end by telling you how do we adhere to these guidelines in unforeseen N2 cities, N2 disease in patients of restricted NSCLC. Now, these are nationwide results from the Dutch lung cancer audit. Next slide. The objectives were, as we all know, that guidelines recommend invasive national staging, and then you look at the suspicious lymph nodes, N1 to N3 or central FDG non-invasive peripheral more than 3 centimeters. The objective of this study was to see how much are people adhering to the current guidelines. I can say that at least in the part or in this place where I practice in my state or in my region, we probably are not adhering to these guidelines which has been discussed in the last 5 to 10 minutes. Next slide. Anyway, the conclusion was guideline adherence in Dutch NSCLC patients with an indication for invasive mediastinal staging is poor. Next slide. The highest unforeseen N2 rate was found in unstaged clinical N1, N2, N3 patients, suggesting that this subgroup can benefit more from an appropriate staging conforming to guidelines. And what is meant by poor in their audit, which they saw? Next slide. They looked at almost 2,238 patients. 43% underwent initial endosonography. 44% of them had a confirmatory mediastinoscopy, which means only a 19% rate of properly staged patients according to the guidelines. So that's where we stand. So we do have guidelines, but are we really adhering to those mediastinal staging guidelines? It is something which all of us should deeply look into and start trying to evolve in that direction. Thank you so much, Pavitran sir. Sir, am I audible?
Yes, sir, you're very much audible. Dr. Deepak sir, can you invite the next speaker?
Thank you, Dr. Dattatreya. Questions we'll take up during the panel discussion.
Sure, sir.
Now I invite the second speaker, Dr. KVVN Raju, Senior Consultant Surgical Oncologist, Basavatarakam Indo-American Cancer Hospital, for his talk on when to operate and when not to operate in stage 3 non-small cell lung cancer.
Good evening, Deepak.
Dr. Raju, please.
Good evening, Deepak. We want to share the screen, please. Can you visualize the screen?
Yes, sir.
Yes. Please go ahead.
So we'll start. Good evening. The lung cancer, most of the patients in our country are diagnosed in the advanced stages. Most of the patients that come to us in stage 3 and stage 4. And if you look at the global current data, close to 60% of the patients, they are in stage 3. Of these patients, a small minority, they get onto the table for a variety of reasons. Now, stage 3 implies it is a loco-regionally advanced disease due to the primary tumor extension to the pulmonary structures or into the mediastinal nodes. Unfortunately, the literature data regarding the survival outcomes, the modalities of treatment is very scanty, and because the disease contains a subgroup of several subgroups of patients, a very heterogeneous population, and not much of a data is available. The recent edition of the 8th edition of the AJCC includes a new substage, that is stage 3C group, which is basically a tumor consisting of T3, T4 with N3 disease. And if you look at this particular slide, there are 17 subgroups of patients. The stage 3A includes patients who are T1, T2, N2 disease, and T3, T4, N0 disease, and T3, N1 disease. These are the stage 3A group of patients. These are the group of patients where, provided you do appropriate staging and establish it is a really resectable disease, and if the surgeon can achieve an arterial resection, then surgery can be contemplated based upon several other parameters. Stage 3B and stage 3C, they are not candidates for surgical intervention. Now, stage 3, T3 disease is a disease which is 5 to 7 centimeters in size, or a superior sulcus tumor, or a patient who has got involvement of the pericardium or the chest wall infiltration. These are all group of patients where an arterial resection can be carried out in a selected subgroup of patients. Now, a patient having a separate nodule in the ipsilateral lung lobe also will fall into a T3 category, and these all patients also can undergo surgical intervention. A T4 again is a group of disease containing, this is a group consisting of several subgroups. Involvement of the proximal airway, the trachea or the lobar bronchus within 2 centimeters from the carina. Patients who has got a diaphragmatic involvement, superior sulcus tumors, and some of the tumors which is invading the esophagus. Among this subgroup, patients who have got superior sulcus tumors and metastasis, a different nodule in the ipsilateral lung lobe. This particular one, where the patient may have one primary in the right upper lobe and a second primary in the right lower lobe, they will all fall into the T4 category group of patients. So highly selected group of patients, T3 and T4, with or without nodal involvement, they can be candidate for surgical intervention. A mediastinal nodal involvement with a T4 disease is not a candidate for surgical intervention. An N2 disease implies a mediastinal nodal involvement of the contralateral mediastinal nodes or a supraclavicular nodes or scalene nodes will become an N3 disease, and these are not candidate for any surgical intervention. Now, generally patients who have got a large tumor, a central tumor, and patients who have got a higher SUV activity on the PET, they have a higher probability of having mediastinal nodes, and they have to be staged with the mediastinal invasive staging systems. Now, MRI is mandatory for all the MRI of the brain is mandatory for all the stage 3 patients. So if you look at this particular slide, only candidates who fall into the category of stage 3A, they are candidates who can be considered for surgery depending upon other factors. Stage 3B and stage 3C, they're inoperable, they're unresectable, they have to go for a chemoradiation treatment followed by other modalities of treatment. So this is a very busy slide. In a nutshell, a patient who has got a T4 tumor, as long as the disease is confined to the primary site with the hilar lymph nodes, they can undergo a surgical intervention in selected groups. A patient who has got a mediastinal node, a T4 disease, is not candidate for surgery. T1, T2, T3 disease, without mediastinal nodes, they will fall into the early stage category, and the treatment of choice in this group of patients is a surgical intervention. On the other hand, if the patient has got a nodal disease in the mediastinum, it becomes an N2 disease, they will fall into stage 3A. Some of this group of patients, they undergo upfront surgery, while the others, they go for an induction chemotherapy followed by surgery. Patients who have got a superior sulcus tumors, generally we prefer to give a chemoradiation and then go for a radical surgery. Now, these are the ESMO guidelines, which is a replication of the previous slide. So T1, T2, 3 tumors without mediastinal nodes, they go for upfront surgery. With a mediastinal node, either surgery or induction chemotherapy or chemoradiation followed by surgery. Now, apart from the stage of the disease, what is important is the overall physical performance status of the patient. his cardiac reserve, and the pulmonary reserve. Even if the primary is resectable, if the patient pulmonary function status is poor or his cardiac disease is bad, they are not candidate for surgical intervention. The patients generally with an N2 disease, if it is a bulky disease or patients who have got a multi-station lymph nodes, generally we don't carry out a surgical resection. In a small selected group of patients, which is extremely uncommon, patient who has got an isolated nodal disease confined to 1 or 2 stations without extracapsular space involvement, they can be considered for surgery. Now, this is one of the trials which looked at it data. We're comparing the CRS with surgery, CRT, chemoradiation plus surgery versus chemotherapy followed by radiation without any surgery. And if you look at this particular data, there is significant improvement in the progression-free survival in this particular group of patients in this particular trial. The other group of patients who have got more advanced disease, they don't gain anything by carrying out a surgical intervention. Now, this is an ER-twisted trial which looked at the more advanced group of patients, and then they concluded that in an advanced group of patients, the surgery doesn't add anything to the patients. So in these group of patients, stage 3B and stage 3C, the treatment of choice is a chemoradiation treatment and followed by the newer molecules if we are a believer. So to conclude, I would say the stage 3 is a very heterogeneous group of patients, and these group of patients have to be dealt in a highly selected centers, tertiary care centers, wherein a multidisciplinary discussion has to take place and then choose the appropriate modality of treatment in the correct sequence so that the patient gets the maximum benefit out of it. In a small selected group of patients, stage 3A, surgery does help the patient and increases the overall lifespan and increases the cure rate. Stage 3B and C, they are not candidate for surgery. They have to go for a chemoradiation protocols. Whenever we are carrying out a surgery, it is important to keep in mind that you achieve an R0 resection, otherwise surgery should not be planned. And a lobectomy is the preferred modality of treatment in the resectable group of patients. Neoadjuvant treatment as a strategy consisting of either chemotherapy or chemoradiation treatment is often employed for stage 3A group of patients, depending upon the location and the requirement. So to conclude, I would say that stage 3A is eminently surgical resectable, but however, a judicious usage of other modalities of treatment is imperative to achieve a good outcomes for our patients. Thank you.
Thank you, Dr. Raju, for the very clear presentation of the guidelines. Now I invite Dr. Niti Praisada, Director of Medical Oncology and Hemato-Oncology, Fortis Group of Hospitals, Bangalore, for a talk on evolving role of immunotherapy in early stage small cell lung cancer. Over to Dr. Niti, please.
Good evening, sir. Good evening, everyone, and thanks to the organizers for having invited me today. My topic is evolving role of immunotherapy in extensive stage small cell lung cancer. So I would start by saying that we all know that lung cancer is the cancer with highest mortality across the globe, and 15% of all lung cancers are supposed to be small cell lung cancer. And the average median age of small cell lung cancer patient is around 70 years. And 50% of these patients would have brain metastasis at some point in time, which is associated with poorer outcomes. Most of the small cell lung cancer patients are also smokers. More than 95% of these patients are smokers. Approximately 2/3 of all these patients have a life expectancy less than 1 year, which is extremely dismal. And when they are treated with EP alone. And this has improved to some extent with the newer drugs, but we have a long way to go. So this has been the milestones achieved in extensive stage small cell lung cancer. And there was a period of stagnation from 1985 when etoposide along with platinum was introduced to 30 years till 2015, in which that remained the standard of care. And in fact, even now, in most of the instances, we would just use EP regimen with carboplatin or cisplatin. And in 2018, first nivolumab was introduced in extensive stage lung cancer, extensive stage small cell lung cancer. And after that, we had introduction of atezolizumab and durvalumab in the early stage, first line setting of extensive stage. So EP remains the standard of care. But recently, we have durvalumab, which has shown great importance and potential benefit in the landscape of SCLC. Well, the current standard of care still remains a doublet. The number of cycle is unclear. And the two important landmark studies, which I'll publish here, one states that 4 cycle of EP is the standard, whereas the durvalumab study with Caspian study shows 6 cycle of EP as the standard. We would try and give PCI, that is prophylactic cranial irradiation, most of the patients, or radiotherapy whenever there's brain metastasis, especially with symptomatic brain disease early on, or PCI later on. We decide whether the patient is sensitive to platinum or not. And if the patient has no relapse-free survival greater than 6 months, we call it platinum-sensitive disease. And in second-line setting, we try to re-challenge with platinum. Whereas if less than 6 months is the disease-free survival, we call it refractory disease, and try to use alternate drugs like topotecan. We use trabectedin derivatives like lurbinectedin, and if possible, a clinical trial wherever available. But we all know that in most of the instances, what we actually give is just best supportive care or palliative care with probably localized radiotherapy, whether it is in the lung or the brain, or just home-based care. But in the recent past, as I said, there has been approval, not just by FDA, but European Union as well, for both durvalumab and atezolizumab. So starting with the important trials, the first line therapy until now, the ORR has been in the tune of 60 to 70%, with the median progression-free survival of about 4.7 to 5.5 months, and overall, a very less than 2 years of survival, with 1 year overall survival just about 40%. Most of these patients only land up receiving the first line therapy. Only about 30% of the patient would actually go to second line therapy, and less than 20% we would consider third line therapy. So what is very important here to understand is the first line setting is paramount importance to get the best results. Approximately 2 in 3 patients of extensive stage small cell lung cancer have a survival limited to 2 years when you give atezolizumab, which is slightly increased when we talk about durvalumab in the first line setting. The 2-year survival rate when you give etoposide along with carboplatin is only about 22% at this juncture. So talking about the Caspian study, which was the first study with an IO in the first line setting, this is a study which allowed use of etoposide along with either cisplatin or carboplatin. This is what we normally do. We would want to have a choice of cisplatin versus carboplatin based on the performance status and fitness of the individual. So this study actually used about 800 patients with good performance status, PS 0 or 1, with life expectancy of at least greater than 12 weeks, with at least 1 target lesion as per RECIST 1.1 criteria. And there was stratification based on either cisplatin or carboplatin. In this, durvalumab was given with EP regimen, which were platinum was based on investigator's choice, 4 cycle at 3 weekly interval, and which was basically followed with maintenance regimen in which durvalumab was given every 4 weekly until progression. It was compared with EP regimen alone, where 4 to 6 cycles, up to 6 cycles were permitted. Primary endpoint was overall survival, whereas secondary endpoint was PFS, ORR, and quality of life. As compared to IMpower 133, which was a landmark study which established the role of atezolizumab along with EP regimen, the difference was the IMpower study only allowed 4 cycles of carboplatin as the platinum of choice. Brain metastases were only eligible if they had received prior treatment, whereas Caspian study allowed brain metastasis even if they were treated in the past or they were untreated, whether they were symptomatic and treated or they were asymptomatic, and EP was given for 6 cycles. So these were the results in which durvalumab along with EP was showed a statistically significant and sustained improvement in overall survival at 12 months, 24 months, and 36 months. So this was the only study of SCLC extensive stage which actually had data up to 3 years. And they showed that at least 3 times more patients were alive with the 3-drug combination with included durvalumab versus EP alone. Median overall survival in this study was 12.9 months, which was only 10.5 months in the EP alone arm. This study was again the first and the only IO which showed long-term survival benefit up to 3 years. As I said, Iron Power was a study which showed median overall survival of 12.3 months, whereas Caspian showed a 3-year overall survival of 12.9 months. This again compares durvalumab versus atezolizumab in the first-line setting. And atezolizumab at this juncture only gives a 2-year OS data of about 22%, which was slightly higher in the durvalumab arm and gives a 3-year overall survival data. At 3 years, in both the pre-specified subgroups, whether it was with or without brain metastasis, whether the patients were smokers or non-smokers, whether they were Asian or non-Asian population, most all the arms favored the combination IO arm. And these patients, the patients who benefited were also the patients who were higher age groups and whether they were given cisplatin or carboplatin. Now, durvalumab showed improvement in terms of overall response rate, which was 68% versus 58% in the EP alone arm. The durability of response at 24 months was 13.5%, which was only 3.9% in the EP alone arm. Based on the fact that which patients had baseline brain metastasis, whether symptomatic and treated or asymptomatic, both the arms favored the brain metastasis arm and combination with IO. In terms of toxicity, the rates of grade 3 and grade 4 adverse event and serious adverse events were numerically lower in the durvalumab arm, almost similar to the EP arm, and the rate of discontinuation in the combination arm was rather low. There were higher incidence of immune-related side effect. And as we all know, the most common immune-related side effect was thyroid events, which could be hyper or hypothyroidism. And most of the immune-related side effects were rather low and easy to manage based on the standard guidelines. At 36 months, there was no new safety signals identified and significantly no change in safety in the combination IO arm. The health quality of life parameters were also restored and almost similar versus the EP arm. The most common side effects included appetite being low. It could be GI side effects like constipation or diarrhea. And some patients had fatigue or dyspnea and nausea. Again, noteworthy is that in this durvalumab was 1500 fixed dose. There was a combination of etoposide along with platinum, which was cis or carboplatin, which was given initially 3 weekly, and in the maintenance arm, 1500 milligram was given 4 weekly. So there was a choice of flexibility and less hospital visits. The difference between IMPA 133 and Caspian trial was untreated brain metastasis was excluded in the IM Power study, and PCI was allowed in both the arms, whereas PCI was actually excluded in some of the patients in the Caspian arm. At this juncture, based on all the data which I've just spoken about, NCCN allows only etoposide along with carboplatin when it is combined with atezolizumab for 4 such cycles, whereas when you're giving durvalumab combination, up to 6 cycles is allowed either with cisplatin or carboplatin, followed by maintenance durvalumab. So in conclusion, the durvalumab is the first IO which has shown benefit and longer overall survival, higher ORR and progression-free survival in all the arms with or without brain metastasis in any race and any fitness level. Thanks so much.
Thank you, Dr. Nidhi, for the very nice presentation. Now I invite Dr. Sushant for the next case-based panel discussion. He is the consultant medical oncologist at Action Hospital, Delhi. Over to Dr. Sushant, please.
Sir, Dr. Sushant will join in a couple of minutes. Can we have a couple of questions?
Okay, sure.
Dr. Nidhi, ma'am, in your practice, what would you routinely prefer for small cell lung cancer, ma'am, extensive stage, upfront immunotherapy, or in patients who come with really poor performance status, would you use it down the lane in your practice, or would you use it as a maintenance therapy? Your opinion on that? Dr. Nidhi?
The ma'am is not there.
Okay, fine.
Nidhi left, I think.
Yeah. I think we have Dr. Sushant. Yeah.
Hi, good evening.
Hi, good evening. Yeah, you can invite the panel, sir.
Yeah, just a moment. Just a moment. So thank you for giving me this opportunity. And what we'll be discussing today is the optimal management of extensive stage small cell lung cancer. And I'd like to invite my panelist, Dr. Vinayak. Is he there? Dr. Vijay Agarwal. Dr. Vishwajit.
Yes, sir. I'm here, sir.
Yeah, I can see Dr. Vishwajit. Dr. Harish.
I'm here, sir. I'm here.
Okay. Dr. Sanyo. And Dr. Swaritika. Yes, she's there.
Yes, sir. I'm here. Hi.
Okay. So,
Two more, sir, sorry for interviewing, two more panelists, Dr. Rakesh Boya Reddy, sir, from Visakhapatnam, and Dr. Abhay Kumar. Dr. Rakesh Boya Reddy, sir.
Dr. Reddy and Dr.
Abhay Kumar, sir.
Abhay Kumar. Fine. Great. So, I'll just a moment. So, are all of them are medical oncologists? All the panelists are medical oncologists?
Yes, sir.
Okay, great. So Mr. XYZ, 72-year-old gentleman, presented in January 2021 with the complaint of chronic cough and hemoptysis. He is a known case of hypertension as a chain smoker. And with these complaints, he went to a chest physician who on the X-ray showed a left upper lobe mass. So he underwent a CT scan which showed a left upper lobe nodule. mediastinal adenopathy and was taken up for bronchoscopy, and biopsy was suggestive of small cell lung histology. And then he was referred to me and I did further testing. So now I want to know from Dr. Abhay. Sir, मैं अभी कॉल करता हूँ, मैं एक मीटिंग में अभी कॉल करता हूँ. So Dr. Abhay, are you there, sir? Yes. So what I want to know is, sir, since the patient has undergone CT scan, would you like to go ahead with any other investigation when he comes to your OPD?
Yes, if a patient is underwent biopsy and already diagnosed small cell lung cancer, so definitely I will do PET CT scan and MRI brain.
Okay, great. Dr. Vishwajit, would like to do anything else, or these two investigations are fine?
Yes, sir. Definitely MRI brain and PET CT.
Anyone who would not like to do a PET scan and would go ahead with the CT scan? I'll rephrase my question. Suppose the patient comes with the CT scan and he already has an extensive stage lung cancer, small cell, and we have done the brain MRI. And if I start the chemotherapy and after 3 or 4 cycles, I do the PET, since it's a small cell is a FDG avid disease, very avid disease. So after 3 cycles, I can do a PET scan and see what is the response. So is it fine, or you would still want to do a PET scan? Dr. Swarika?
Yeah. Yes, I actually would be okay with a CT scan for an extensive stage. I understand that PET might upstage it in more than 70% of the cases. I would discuss it with the patient, but I would not let PET deter me from starting therapy in an extensive stage.
Okay.
So I would be okay with the CT scan. I would, yeah.
Okay. Dr. Rakesh Reddy?
Yeah, so if the patient has already got a CT chest and a brain MRI, like in this case, and we already know that this is an extensive stage SCLC, doing a PET will not change my treatment decision, but it offers me ease of following that patient up, especially if the center that you are practicing in has a PET CT, and it offers me an ease of follow-up. But again, as the previous panelist was also saying, it is something that I will discuss with patient and leave to the patient. I would not specifically ask. I will do an ultrasound abdomen, which can be very easily done at the same visit, and that's about it. I would not specifically press for a PET scan, but if it is something that can be done at baseline, then fine. It offers me ease of following that particular patient up.
Okay, fine, great. So that's what the NCCN also says, that CT scan is a good enough investigation, and if it is helpful for us and it has given us a diagnosis that it's a extensive stage disease, then we might just go ahead with MRI brain without doing a PET scan, and we can go ahead with it. So, however, this patient had already undergone CT scan, but patient, I told them I don't require a PET scan, but he himself told me, sir, PET scan kara ke dekh lete hain. Rest of the doctors have told me, yes, PET scan should be done. I said, okay, fine. If you want to get the PET scan done, I'll get it done. So this was the PET scan, and it shows that on the heterogeneously enhancing mass in the left hilar and perihilar region in the mediastinum, left supraclavicular lymph node, and left lower lung lesion, possibly inflammatory. So this was clearly an extensive stage disease. So so next question I want to ask Dr. Sanyo, sir, what would you like to do next step? How would you proceed? The patient has this disease, PS1, echo is fine, everything is fine. So what would you like to do next? What would be your choice of therapy?
Dr. Sanyo is not there.
Dr. Sanyo is not there. Dr. Harish? Is he there, Dr. Harish?
Dr. Harish is here. My choice of chemotherapy will be cisplatin and etoposide. 4 cycles I usually use.
4 cycles you'll use. Okay. So would you like to add anything else in your chemotherapy regimen?
Specifically, is this question relating to other chemotherapy or immunotherapy like that?
No, I like to know immunotherapy. Yes. Do you want to add immunotherapy or would you like to refrain from adding immunotherapy?
Well, as compared to non-small cell lung cancers, we should be aware that the addition of immunotherapy does not lead to great outcomes. But yes, as compared to cisplatin and etoposide, when we add immunotherapy, we understand that the overall survival is improved by around 2 months. And we explain this to the patient. And if finances is not a problem, then we would add an immunotherapy, given that the toxicity rates are not much different. But so yes, the benefit is limited, but there is a small benefit, definitely.
Okay. Dr. Swaritika, what would you like to do?
Yes, I would actually prefer, like Dr. Harish said, cisplatin etoposide combination. 4 cycles is what we routinely practice in limited stage disease. At this point, I don't think addition of immunotherapy is supported by any data. And given that we don't expect dramatic improvements in OS, I am not sure I would counsel it, because even if I do counsel it, it always, and it's such an expensive treatment, I think it causes more confusion. I would not want to add any other irinotecan or any other chemotherapy option, because I would stick to cisplatin etoposide because it's well tolerated, as well as the evidence is maximum for that chemotherapy regimen.
Okay. So if money is not a constraint, he is a government employee, CGHS beneficiary, and money is not a constraint, what would be your take on that?
No, sir, I don't think at this data, even science, at this point, I don't think even science supports. Oh, sorry, I thought we were talking about the limited stage. I'm sorry. In an extensive stage, I would give 6 cycles etoposide, carboplatin preferably for my comfort in ease of administration. And I would give durvalumab over atezolizumab. It's just because it's my treatment comfort base. That's all.
Okay, so in extensive stage, etoposide with platinum, either carboplatin along with immunotherapy. So fine.
Yes, sir.
Okay, fine. Then Dr. Vishwajit, what would you like to do, sir? So score
Yes,
is
sir.
1-1.
So I have personally used both patients only chemotherapy as well as a patient on chemoimmunotherapy. I have seen a much better response. 2 patients that I had added chemoimmunotherapy have gone into CR at the end of 4 cycles. So definitely I have seen great responses in extensive stage small cell lung cancer. I wouldn't give cisplatin. I would still go with carboplatin itself, because a lot of patients are at presentation have severe SVC syndromes, and giving cisplatin with so much of fluid makes it more difficult. They go into volume overload and all that. So, and we also have data that there's no difference between cisplatin or carboplatin in extensive stage. So I'd go with etoposide, carboplatin with the addition of an immunotherapy agent.
Okay, Dr. Abhay, what would you like to do?
This patient is elderly, so definitely I will consider carboplatin plus etoposide, and definitely I will consider immunotherapy. But immunotherapy choice here, so since both studies, IMpower 133 and Caspian, so both have shown survival benefits, similar response rate, around similar PFS. So cost will make the decision for me here to consider the choice of immunotherapy.
Okay, so 3:1. So now I want to know, we already know that no other chemotherapy other than cisplatin and etoposide or platinum with etoposide has shown benefit. We have used adriamycin, we have used pemetrexed, but none of them have shown as good result as EP. So EP remains the standard of care. However, now since 2018 or 2019 onwards, we have the benefit of giving immunotherapeutic agents, and both Durva and Atezo are approved in first line immunotherapeutic agent. But I would now like to ask that if the patient is not, how many patients are able to take second line therapy? When suppose we have given just cisplatin etoposide, how many of them when relapses are able to take the second line chemotherapy? And Dr. Vishwajit? So if you have not given immunotherapeutic agent, I am just talking EP, and the patient has progressed. So how many of your patients are able to take, or are the PS is good that they are able to take second line?
Yeah, I definitely agree, sir. Patients who have progressed on, say, first-line chemotherapy alone, by the time we reach a situation where they need second-line chemotherapy, the performance status and the clinical situation would have worsened significantly, and not many people will be fit for a combination chemotherapy. At that point, we either try a second-line chemotherapy, or we usually tell them for advice for a best supportive care. So in hence I would definitely add immunotherapy in the first line itself rather than adding it in the second line.
So Dr. Reddy, would you agree that you would like to give the
mostly
best benefit in the first line? Because majority of the patient will not be able to take the second line.
Yeah, only about 30 or 40% will be able to take second line. That is for sure. It is as per the data as well as the real world situation that we regularly face. And if at all we have to use immunotherapy in small cell lung cancer, it is only in the first line setting. The first line maintenance did not work. The second line did not work. Third line did not work. So if at all, if you have a patient who has the wherewithal to take, or has some scheme beneficiary, as you were mentioning, I think it is better to try immunotherapy in first line. No other setting works.
So Dr. Majumdar, do you agree or do you differ? Dr. Swaritika Majumdar, do you agree or do you differ?
Yes, sir.
You agree to give immunotherapy?
Yes, definitely. I think one of the reasons both nivolumab, ipilimumab combination as well as pembrolizumab failed is because they used it as maintenance rather than starting at cycle 1. And we know that after 4 cycles to 5 cycles, the CR which is attained tends to slip away, and they usually relapse within before completing 6 cycles of chemotherapy. So definitely, I would start immunotherapy first cycle, first line.
Dr. Abhay,
I'm sorry, sir.
I'm saying first time is the best thing. You would like to give best shot
in
the first time.
Yes.
Dr. Abhay?
Yes.
So pardon me, sir. Voice.
So do you agree you would like to add best regimen in the upfront? You would like to convince and try convince?
Definitely, sir. So I will consider immunotherapy upfront along with the chemotherapy in the first line.
Dr.
So that is where there is strongest phase 3 data is there.
Yeah, I'll come back. I'll come back to that. Dr. Vishwajit, do you agree or do you differ?
I agree, sir.
Okay. So any of the panelists who differ that they are not convinced that they would not like to add immunotherapy upfront? Any of the panelists, or they would like to at least give the data to the patient and tell them that this is the available drug which is present in the market. So I think everyone would agree with that. So that's why the NCCN guidelines also say that carbo etopo or cisplatin etopo, any of the drug you give, durvalumab is approved as a frontline treatment, followed by maintenance as well. So what would you like to consider as the drug of choice in immunotherapy, Durva versus Atezo? Dr. Vishwajit.
Yes, sir. One thing would be definitely the eligibility of which platin compound to be used. As we know, atezolizumab, the trial took into consideration only patients who, they received only carboplatin. And the second one is the presence of brain metastasis at presentation, and if we would be considering prophylactic cranial irradiation during the course of our treatment. Though the role of PCI has been debated in extensive stage, most of us do continue to give PCI in our patients. So taking into these consideration, I would definitely, for patients who already have a brain metastasis, or if we are considering cisplatin, then durvalumab would be the choice. Otherwise, atezolizumab. This apart, if there are any, if you look at the financial aspects, there are certain changes between the two drugs, so we would have to choose accordingly.
Dr. Harish. So what makes you choose one over the above? Do you find any differences, or you find both of them equal? How do you choose in your routine day-to-day practice?
So from my perspective, yes, the trial, there was cisplatin was not used in the Caspian trial, but I think both immunotherapies are reasonably, the amount of benefit has been almost same with either of them. Even in the side effect profile, there was no difference. So there is not much to choose between them except for the finance.
So suppose the data says that in IM 133, patients of cisplatin were excluded. However, if you want to use cisplatin, the patient is fine, his creat clearance is fine, his hearing is fine. So you want to use cisplatin, and we don't have the data of atezo with cisplatin. So I think that gives an edge of Durva over atezo. And also the brain mets patients were also included in the Caspian study, although the PCI was optional in these patients. So the real world data, the real world practice allowed the treatment with either cis or carbo. So that is the edge of Caspian. It included the asymptomatic and untreated brain mets patients. However, the IM 133 had excluded brain mets patient, and as compared against 6 cycles of chemotherapy with optional PCI. So these real world data, real world practices has given an edge of Durva over the other immunotherapeutic agent.
Sorry for intervening. You have 3 minutes left.
Yes. Thank you. So patient was started on chemoimmunotherapy. He received cisplatin etoposide plus Durva 3 weekly cycles, and after 3 cycles, he had a partial response, as can be seen on the scan. We continued with 3 more cycles, 6 cycles, and he had achieved stable disease. He was almost in CR. Now the question is, would you like to give PCI? Just how many of are comfortable giving PCI? Dr. Vishwajit.
Yes, sir. In my practice, I have seen definitely giving a PCI does delay the development of brain metastasis, but eventually most of them do develop. But the trials have shown that the administration of PCI does delay the development of, but there's no overall survival benefit. But the thing is, on the other hand, we have administering PCI does cause deterioration in the quality of life.
So my question is, do you give or you don't give?
In
asymptomatic.
I do discuss the pros and cons with the family, and then I take a call, sir.
Okay. Dr. Reddy?
For a prophylactic setting in a patient who did not have a brain metastasis upfront, I would not give PCI. I would rather put the patient on surveillance MRI. I don't want to follow deterioration for about 13 or 15 months or 18 months that the patient is going to survive. That is my primary importance.
Yes, sir. I agree. I would not recommend PCI for a patient who has extensive stage with asymptomatic and no brain mets. I would.
Sir, I think if patient received chemotherapy, definitely I will give PCI. But for patients who have received immunotherapy, actually PCI has not been done, especially for the durvalumab. I don't know how to incorporate when patient received immunotherapy. So I'm not sure about in the patient received immunotherapy, but definitely patient if received chemotherapy.
So PCI, most of us would like to defer till the patient is asymptomatic, because we feel that the cognitive dysfunction will improve or will deteriorate because of the PCI. And we would like to take the advantage of whatever immunotherapy has to give in the brain mets patient. So the current status of the patient is, we can see the scan of 18th February, that he is still into CR and doing well and is asymptomatic. So to summarize, the first line Durva plus EP has shown a sustained improvement in OS compared with the robust control arm. In the real world practice, we have the options of cis versus carbo. Benefit of Durva plus EP was observed across all subgroups, including brain mets patient. Survival tripled at 3 years with use of Durva plus EP, and Durva offers once monthly dose, and safety remains manageable, and there is no effect to the quality of life. With this, thank you so much, my esteemed panel, for a wonderful discussion. Back to the organizers.
Thank you, Dr. Sushant, for the very nice panel discussion. Now we'll go for the next much awaited, the guest speaker lecture. This by Dr. Mark David Vincent. He's a medical oncologist at London Cancer Regional Cancer Center, Cancer Care, Ontario. And his special interests are in management of lung and gastrointestinal cancer and research into the reversal of cytotoxic drug resistance by means of gene therapy. He is also associate professor at the University of Western Ontario in the Department of Medicine, the Division of Medical Oncology. Vincent.
Hello, can you see my slides?
Please speak over. Yeah.
Yeah.
Not yet, not yet.
Are you able to see them now?
No, we can see you only.
Okay. How's that?
Yes, it is coming. Yes, please go ahead.
Okay, so good morning, everybody. I'm going to be talking about the management of non-small cell lung cancer stage 3, courtesy of AstraZeneca, to which I'm grateful. There's my disclosure slides. I'm happy for anybody who wants these slides to get them through the company. I'm going to talk about definition and incidence and treatment of history of stage 3, the immune checkpoint concept, 5-year update of the Pacific trial, the role of the MDT, and the use of durva in sequential versus concurrent and in patients with a druggable driver. So stage 3, just to move through this quickly here, is not the early resectable one. It's not the late, very distant advanced metastatic. It's those in between. Mostly it's patients with mediastinal or supraclavicular nodes, sometimes very aggressive local tumors as well in the T3, T4 range. So there's many combinations of T stage and N stage, and won't go through all of it. I'll assume that this audience is familiar with stage 3. Epidemiology, it's about 25% of non-small cell lung cancer. The survival is around about 20%. There is a bit of a benefit from adding chemotherapy to radiotherapy. In a meta-analysis, it was very, very modest, but other studies have shown a bit of a better benefit. If you use concurrent chemotherapy as opposed to sequential, there is an improvement, but it's not that much. So one of the points I'm going to be making here is that it's better to do concurrent, but sometimes, because of frailty and age and tumor size and so on, you have to do sequential. And the ESMO guidelines have in fact recognized that sequential chemoradiation is a valid alternative in some people, but noting that it's preferable to use concurrent. And in fact, the original pioneering Dillman study used sequential chemoradiation with cisplatin vinblastine followed by radiotherapy. And this showed this really major improvement in median survival and an increase in the tail on the curve, going up from about 5 to about 20%. But since then, we've come to recognize that there are more toxicities if you use concurrent. Certainly the rate of esophagitis is much higher, whereas with sequential, it's only about 4% as opposed to somewhere between 20 and 40% of patients getting fairly severe esophagitis, which is reversible, by the way. So I'm not speaking against it. It's just that you have to be able to tolerate the esophagitis if you want to use concurrent. In terms of 5-year overall survival, well, there's been a bit of an improvement, but not much, to be honest. The sequential 5-year survival recently is about 10%, about 15% for combined concurrent. We have hit a bit of a wall about 10 years ago, so we've tried just about everything, including consolidation platinum. It doesn't work, as you can see from the study. We actually also did a consolidation docetaxel study, which failed, to everybody's surprise, to improve outcomes, did increase toxicity. We've tried to increase the radiotherapy dose from 60 gray, which is standard, up to 74. This was actually worse. So we've gone back to using 60 gray as a standard. So we've had many attempts including vaccines. We're using alternative chemotherapy like pemetrexed, which is kind of only equally effective, but is less toxic in the non-squam. So really, until recently, active surveillance, once we finished chemoradiation, has been the standard of care, and you're just going to wait really for these people to relapse. And we know that most of them relapse. Certainly surgery has been tried. The famous intergroup 0139 study randomized people for completion radical radiation versus the addition of surgery onto 45 gray. Overall, there was no survival benefit. There appeared to be a little bit of a benefit in people who had more restricted disease and who might be able to get away with a lobectomy. But you don't know if you're going to be able to get away with a lobectomy a lot of the time. If you had into a pneumonectomy, it is definitely worse to do surgery. So it's more dangerous. So surgery, I'm not arguing that surgery never has a place. Surgery certainly can improve local control, as we see here in the 139 study, but there is no difference in systemic failure. There's no significant difference. So surgery does not provide a substantial benefit for systemic control, and most of these people will die of systemic disease, as illustrated in this next slide, which is a very good study from a retrospective study from South Korea, where they had almost 600 patients who were the kind of best of the best, really good, resectable N2 disease, single station, most of them, triple therapy, chemo, radiation, surgery. By 5 years, the progression, the disease-free survival was only 30%. 70% of these people had failed, despite being very selected patients, good for surgery and so on. 80% of the recurrences are systemic. Okay. So the problem with surgery is not the technical excellence of our surgeons, who are very, very good and very skilled. The problem is the horse is already bolted. There's no point in trying to close the stable door. This is a systemic disease from presentation. Most of these people, overwhelming majority, will have already systemic disease, micrometastases. So we have to think a bit differently. So we have the immune approach. We have this cancer immunity cycle where these cancer cells are shedding antigens. They're processed by dendritic cells. There's a checkpoint in the lymph node called CTLA-4 that can block the lymphocyte clonal expansion. If they can get around that checkpoint, they get back into the bloodstream, get to the tumor, and then there's another checkpoint called PD-1, PD-L1 can exhaust the T cells and inhibit the immune system. So there are checkpoints that kind of frustrate the immune system. Now, radiation is part of the solution here because it results in many, many changes, and I don't have time to go into them, but it improves trafficking of immune and inflammatory cells into the tumor, so they're not excluded anymore. It changes the cytokine profile. There's a lot of so-called immunogenic cell death, but one of the things it does do is raise the level of PD-L1, and PD-L1 is actually inhibitory to the immune system, as we've seen. Chemotherapy can add benefit by releasing a number of proteins and displaying, for example, calretinin or ATP and so on, which can manipulate the microenvironment and in particular help the maturation of dendritic cells. That helps them process the antigen and show it to the lymphocytes. But again, we have this problem of elevated PD-L1. So as a solution to that, we have durvalumab as an anti-PD-L1 antibody, which can block the high PD-L1 on the tumor cells and prevent this inhibitory signal. It can also block the PD-L1 on other immune cells as well, which is an inhibitory signal. And so the balance then shifts to activation of the T cells, which are then much more prone to exercise an anti-tumor effect because they will recognize the tumor antigen because it's mutated. So we have now the update of the PACIFIC study, which incorporated these concepts. PACIFIC study started some time ago with over 700 patients were randomized if they were good performance status and had chemoradiation with no evidence of disease progression. So they had to have concurrent chemoradiation, no evidence of disease progression, good performance status, randomized 1-to-1 between durvalumab, 2-to-1 between durvalumab every 2 weeks for a year and placebo, with the co-primary endpoints being the PFS and the overall survival. This has now been published. We have here the 5-year updated overall survival, and we see the curves split almost immediately. It's actually extraordinary how quickly these curves split, and they stay apart. We can see that by 5 years, just in terms of the crude survival, understanding that, some of these people are dying of other diseases. So it's really more important to look at the progression-free survival if you want to know the true protection from the cancer. But there's about an extra 10% overall survival. If you look at the progression-free survival out at 5 years, there's an extra about 14% of people, it's almost 1 in 6, has freedom from cancer, freedom from cancer recurrence. We know when this cancer occurs in these people, most of them, it's advanced systemic disease and they will die. So this is a major achievement, as shown in this next slide, which is, again, a 60-month, 5-year update of time to distant metastases by blinded review. You can see there's early separation, large separation of these curves, and a massive amount of protection from systemic failure. And we can see that there's benefits in smokers and non-smokers, and some benefit in the 5-year survival, what looks to be in these patients with EGFR mutated non-small cell lung cancer, of which there are not that many in the study, but it does seem to be beneficial, and we're happy to do it. That's the PFS. So there was a concern about the PD-L1 negative patients because it looked like there may not be a survival benefit. And in fact, a 5-year update shows that the confidence intervals are very wide. The point estimate is very close to 1. And this study was not powered actually to look at PD-L1 negative patients. It was powered to look at more than 25% versus less than 25%, where it's definitely beneficial. But if you look at the progression-free survival, you do see that the point estimate is well to the left of the unity line. And we are quite happy in Canada, where we're careful about money, not to worry about PD-L1 status. We know that PD-L1 is assessed prior to radiation. When you radiate people, it goes up. If you put the needle this way or that way, you get a different result. So we do not use PD-L1 status as a restriction criterion for using and prescribing this drug. We do know that the patients who got cisplatin had a bit more of a benefit than the carboplatin patients. We do know that patients who were put on early at less than 14 days had more of a benefit than those who were put on between 14 and 42 days. We also know from a very early readout that of the study that there's increased shrinkage, there's better tumor shrinkage on the development. So it continues beyond the chemoradiation, and there's more tumor shrinkage on the development compared to placebo. And we do know that symptom control from cancer is correlated with disease shrinkage. And so that is an additional benefit. What about side effects? Well, turns out, there's a little bit of all-grade pneumonitis, but it is really, to some extent, radiation pneumonitis, and most of it is grade 1, grade 2. There's very little grade 3 or grade 4 pneumonitis, and it's not very different from placebo. This is a placebo-controlled trial. There's, of course, a little bit of pruritus and rash, and a little bit of hypothyroidism is what you expect from immune drugs, but it's very mild and they're easily manageable. Any kind of pneumonitis here, you can see there's about a 4 or 5% increase, but it's not grade 3, grade 4. That's not to say it can't happen, and we'll talk a little bit about it. Leading to discontinuation, very few people have to discontinue, maybe 1 in 20 because of this drug. But if you look at the relapse here, you see that, as I said to you, in the 139 study with surgery alone, surgery provides a benefit in local control, but there is no benefit in systemic recurrence. If you look at the patterns of relapse in PACIFIC study, you see protection from lung, to some extent, lung relapse, local relapse. You see protection from lymph node relapse. You see protection from brain, which is down by 50%. You see protection from liver, which is down by about 1/3 or more. You see protection from bone, which is about 50%, and adrenal. So you see this massive protection from systemic failure, not just local failure, which you get from surgery, but both local and distant. And so this is the breakthrough of this new technology in this disease, where we really haven't had any progress for about 30 years. It looks like that this strategy is curing people. So when you see these very prolonged separation of the curves out at 5 years, it's looking like it's not just shifting the curve a bit to the right and improving median overall survival. It looks like, and it certainly does do that, from about 30 to about 48 months, But it is looking like there is a really decent tail on that curve that shifts the cure rate up by somewhere between 10 and 15%. There's a huge program in resectable and stage 3 and advanced non-small cell lung cancer with durvalumab, and I'm sure the company be happy to tell you about that. Just a little bit more about sequential versus concurrent. This is a real-world study done in Australia and Europe that 1,400 patients, about 1 in 6 got sequential, 15% got sequential. Who got sequential? Well, it's older people with bigger tumors. That's not a surprise. The progression-free survival overall in the study was a bit better than in the Pacific study, but that's not really, it's difficult to tell in a real-world kind of retrospective thing, even a prospective real-world thing about PFS. But if you look at the survival, concurrent versus sequential, it's almost the same. And this really shows that, even in these older patients with bigger tumors, you can get almost as good a result with sequential as opposed to concurrent. We're still saying do concurrent if you can, but sequential is okay. And there are many people who can't tolerate concurrent. And you see by PD-L1, there's not that much difference. There is a difference between adenoids and squames, but that's a different story. And we know that for a long time, squames do not do as well. Again, the incidence of pneumonitis very acceptable, and severe pneumonitis that requiring treatment with steroids and immunosuppressants is not that common, but you need to know how to do it and be prepared to do it. So he has a case report of a 75-year-old man. He had a stroke. He was worked up. He was found to have this lesion up here, this led to looking at the mediastinum where he's got N2 nodes. There's the PET scan showing the primary and the nodes in the hilum and mediastinum. He has a biopsy. It's poorly differentiated, very strongly PD-L1 positive, 50%. Next generation doesn't show any actionable mutation. He's referred to the MDT. We used cisplatin vinblastine actually because we didn't have a topside at the time. There was a shortage, to be followed by 1 year of durva. So you have to tell him that this is on the cards down the road. So this CT scan is reported as being improved. So we check it. We pre-book it to make sure about 1 week after the end of radiation, we've got a CT scan teed up. So it's all ready to go. And he swings right onto durvalumab within about 2 weeks. And he just runs through it very, very smoothly, despite the fact he's 75 years old. 3 years later, he gets flashing lights in his field of vision. And he's got some edema here on the CAT scan and a clear metastasis here on the MR. This is excised by surgery. It actually goes to surgery. It's PD-L1 intermediate. He has a P53. It appears to be the same tumor because we restaged him, and he's recovered nicely. And now he's a curative intent again because we've irradiated stereo. People more than 75 years get a benefit from this, same as people under 70. So we asked ourselves, should we have given this to this guy? Yes, because 75, he tolerated it well. He's had a metastasis in his brain, yeah, but that's the only site. It's a single site. It's been excised, and it was 3 years later, and now he's curative intent again. So I'm fairly confident that we did the right thing to give it to this gentleman. Critical role of the MDT because of COVID. There's been issues. Fewer people discussed. We know that you can use telemedicine. That this can be a strategy to get over this problem, to communicate with the patients as well as your colleagues. We know that there's, people get to chemo and radiation as quickly if you use telemedicine. This is from New York. There's a little bit of a delay to surgery. Surgical patients may not be so good. You need to have a core MDT. You can make it more sophisticated with immune, genetic MDTs and so on, but you need a core MDT of radiation, medical oncologists, radiologists, thoracic surgeons, nurses, trials people, palliative specialists, and pathologists. That is the core, and you absolutely need that to discuss complicated issues around management and treatment. And we know that people do better in academic centers because there's more exposure to new drugs, to trials, and that people are just better informed in academic centers. This doesn't mean that we neglect people out in the district. Canada is a huge country, so we need to use telemedicine, but we try to make sure that people get an opinion within an academic center, and the practice can then be carried out in satellite centers. So this is the model, and we know that it works. Here's in the United States, 45,000 people, only 23% with stage 3 got guideline concordant treatment, and they did better. You can see the dashed red line here. They did better than the people who did not get guideline concordant treatment, and they had a worse hazard ratio, 1.42. So it's really important to try and get equity of outcomes across your country. We know India is huge as well. I know India well, And so we need to get the benefits, not just for people who can make it into an academic center, but find some technical means to get it out there so everybody can benefit. What about driver mutations? We know the story with EGFR and so on, but KRAS, BRAF, and MET14 skipping, for sure, those patients are known to benefit from immune therapy. Obviously, they benefit from, if there's a druggable driver, that's beneficial, but some of them do benefit from immune therapies. HER2 mutations, and EGFR mutations, some of them benefit, some of them don't. Okay, ROS Ret ALK, there's not such good data for benefit. But in the Empower 150 study, we showed a better, and I'll just show it here, a better overall survival in the EGFR mutated subgroup. Again, about 30 patients, not that many in each arm, from the addition of atezolizumab, which is an anti-PD-L1 drug. So there is definite evidence that EGFR can benefit. EGFR mutated patients can benefit. And we've seen that, as I've said, in the non-smokers and the EGFR patients in the Pacific study. There is a LAURA study, which looks at stage 3 chemoradiation and then randomizes if they're EGFR mutated to osimertinib or placebo. We don't have the results of this yet. Will it be better like the ADAURA study in adjuvant? Maybe it will. So right now, we're happy to put EGFR patients on durvalumab. We'll get the LAURA data. We'll see if we have to change down the road. So here's just to finish off a very short case report. The 52-year-old female from the Philippines living in Canada notices a lump in her neck. She's a never smoker. There's the lump in her neck. There's the big mass in the hilum. There's the mediastinal node. There's the biopsy showing glandular formation from cytology, which is TTF1 positive. And the rest of her staging is negative. This PD-L1 intermediate, by the way. And here is her EGFR. She has an exon 18 sensitizing mutation. And here is her baseline chest X-ray with the right hilar mass. And here is a PET scan showing mediastinal and supraclavicular adenopathy. And this hilar mass, she has 2 cycles of cisplatin etoposide, 60 gray. It's well tolerated. And there's the CAT scan. It's showing, and here's the X-ray. You can see there's been a response. She's now started on durvalumab because that's what we do, and that's what we're happy to pay for. After 2 cycles, she starts to get a bit of a cough and a bit of shortness of breath. And we do look at the chest X-ray. You can see it's kind of, there's loss of volume in this right side with some post-radiation changes. The CAT scan seems to indicate there's radiation fibrosis, but it's fibrosis within the radiation field. We do not see a more diffuse pattern. So we think this is more likely to be radiation pneumonitis rather than durvalumab. But nonetheless, out of an abundance of caution, it's reasonable to hold the durvalumab, put the patient on steroids. But by about 3 months, we were able to wean her off the prednisone. We restarted the durvalumab at cycle 3, and we're now just continuing it. She's just had cycle 8, and she's quite okay, and she's fully intend to proceed through to complete the full 12 months of durvalumab at 12 monthly cycles. Immune-related adverse events, just to make the point that the PD-L1 is less associated with PD-L1 is less associated with pneumonitis than PD-1, probably, and that's less associated than CTLA-4, probably. So the rate of it appears to be low, but you need to understand it is a possible thing that can occur. You need this. Grade 1 is probably okay just to continue and watch. Grade 2, you're into oral steroids. Grade 3, probably IV steroids with methylprednisolone, and certainly grade 4. And if they fail steroids, which is very rare in my experience, consider infliximab. And so this has been analyzed in this particular paper, which understands and particularly emphasizes the clinical presentation, the risk factors for what a respiratory failure really is, like COPD and interstitial lung disease, where you have to be really very careful about the radiation dose, how you configure the radiation field to make sure you don't violate the V20 specifications. And understand from the patient point of view that there could be a radiation pneumonitis risk, and that the durva may propose a bit of an additional risk, but it's not much, and know how to manage it, basically. There's lots of different patterns of radiation pneumonitis: ground glass, tree and bud, organizing pneumonia. But the key thing is to try to figure out, is the pneumonitis within the radiation field, or does it extend outside the radiation field? If it's within, it's probably just the radiation. It means it's reasonably safe to go back on the durvalumab once people have settled down. If it's very severe disease and outside the radiation field, you may want to permanently discontinue durvalumab. This is very rare in my experience. So that, my colleagues, is my presentation, and I thank you for your attention.
Thank you, Dr. Vincent, for the very excellent presentation. I have a question. Suppose one of your patients was EGFR mutant. So instead of immunotherapy, was it okay to give osimertinib?
I don't think it's wrong to give osimertinib. We're from ADAURA. We know that there's a very big benefit in the post-surgical adjuvant for stage 1, 2, It's just that we don't have the data from the LAURA study yet. One of the problems with giving osimertinib up front before you've got metastatic disease is that, firstly, how long you're going to give it. 2 years, 3 years, it's not a cheap drug. Down the road, what happens if they relapse? Then you can't use the osimertinib anymore. So the other strategy is to go with the durvalumab in the stage 3 setting for 1 year and then keep the osimertinib in reserve until we get the LAURA data, which may direct us to do something different. We have an open mind about it. But what you should not do is use durvalumab and osimertinib together at the same time, because that is an unacceptable pneumonitis risk.
Thank you. Any other questions from anybody? Dr. Arun? So there are no more queries. I thank Professor Vincent for the very excellent presentation. Now we'll go on for the next panel discussion. There's case-based discussion by Dr. Arun Vaidya. He is the consultant medical oncologist at Aster Medcity, Cochin. Over to Dr. Arun, please.
So thank you very much. Please enjoy your meeting and hope to see you in person at some time. Goodbye.
Bye.
Sorry, I'm audible and my screen is visible.
Yes, please go ahead.
Right. Yes, sir. Yeah. So today in my panel, I have surgical oncologist Dr. Satish Pawar, and I have the radiation oncologist Dr. Pragna Sagar, and I have 4 medical oncologists, Rekha Bansal, Dr. Sadhvik, Dr. Niti Tandon, and Dr. Raji. I hope all are here. Yeah, very good. So we had an excellent discussion by our invited speaker, who is a very learned person. He has got good experience about immunotherapy also. And the slides which have been provided to me are almost similar to what he has also discussed there. So maybe in the whatever time we have, we will discuss what are our practical issues and how we deal with such cases. That is the otherwise the slides at the trials all are almost similar. So this is the case. So the case came in March 2018, 52 years, chief complaint of weight loss of more than 10 kg. The cough was there without much of any comorbidities. Anyway, from an academic perspective, we had started an X-ray. So it showed there was radiopacity was there in the left upper and middle of the left, and it showed some findings also were there. So anyway, we go for a CT chest, and the CT chest showed there was a large lesion. So again, what the speaker showed, it was a small lesion, and so if you just see, you can see this is the classical lens which we get, and the speaker showed a case in which there was a very small lesion with a small mediastinal node. So maybe this itself makes a difference. Why our patients, though we are not getting the results which are there in the trials continuous. So maybe this is an indicator of that. So this is what we see day in, day out, huge lesion sitting in the lens. We don't know the reason for that. So the PET showed almost 80 to 70 centimeter lesion, which is affecting the costal and mediastinal and the apical segment. The mass is supporting the arch of aorta and encasing the left in the upper lobe bronchus with mediastinal ligaments. So we had initial talks on how to approach the mediastinum. There was a talk by surgical oncologists also. But definitely I'll get to have an opinion from the panelist, Dr. Satish Pawar, what his thoughts on this lesion.
Yes, sir. It's a locally advanced lung cancer. So practically most of the people what we see have poor lung reserve most of the times. And once we have that, we are not we don't keep surgery as an option at all. So most of our patients go for chemoradiation, and even disease wise, we would prefer chemoradiation over surgery in down the line also.
So I think that this point was also touched upon before, because stage 3 is a very heterogeneous disease, and there is a discrepancy between the clinical and the pathological state. But maybe if you're really going for means you are following the guidelines and doing the proper staging, we can try to avoid this discrepancy. So, and MDT importance was also touched upon. So we should have surgical radiation medical oncologists together. So as a surgeon, I am sure that this will be the points which you will like to tell, because you already talked about the pulmonary and cardiovascular function, and what about the mediastinal node involvement. So what are your thoughts? Means routinely in your OP, rather than the guidelines, we know just 20% in the Dutch are following the guidelines, as was told in the initial talk. So how many patients will you be able to do justice for a mediastinal nodal stage? Or what is your approach to that?
So most of the patients we do EBUS. Okay, but say for example on PET itself we have a bulky nodal disease, and we definitely know that is N2, and we know that surgery will not be the choice of treatment for this patient. We would, rather than subjecting them for an additional investigation, we would directly go for chemoradiation based on our PET scan findings.
So again, multiple nodules in the same lobe. Lobectomy is the preferred one. Pneumonectomy, I know, means what are your thoughts on that? Pneumonectomy was repeated again and again that we should avoid pneumonectomy. Why do you think that is the reason? Why pneumonectomy? Your practical problems with that?
Yeah. So as I've already, we were talking about the poor lung reserve. Apart from that, whatever studies they have said, say for example, you give neoadjuvant chemotherapy or chemoradiation, downsize the disease, subject them to surgery. So studies have definitely said that whenever you have done lobectomy, they do better than a patient who have undergone a pneumonectomy. So even overall survival decreases once you do a pneumonectomy rather than a lobectomy.
Survival also matters. So
yes.
So this was the data which I think is a Chinese publication, which showed about the multidisciplinary team is the best thing. I know it's not very easy in our whatever settings we are working. Most of the times the surgeons may have seen and operate, and then they come to us. But as far as possible, we are trying to do an MDT. Although the classical everybody sitting in a room is not happening, maybe we can call our speak to people over phone. So maybe we have to move ahead with the times. Like everyone sitting in a room may not be possible now. So maybe we can just have a video call with 3-4 people involved for a case on a case-by-case basis, and have discussion record and keep that. So maybe I also should evolve to that. So anyone is doing that techniques, I just asking like this Zoom recordings on for an MDT for a given case like that, a practical aspect. Have you done that before your settings anywhere?
Yes. So most of the times we are on the same floor, so it's easier for us with sitting in front of the packs and checking the PET scan and evaluating ourselves, and then at least finalizing the plan of the patient initially itself.
Yeah, because the classical academic centers where once a week everyone gets together for a meeting, I don't know whether it is really it's possible nowadays. But at least for a given patient, if all of us can be together, I think that itself will have an improvement out. So that is again shown in this data. So I think management of N1 disease versus management of the N2 disease. So that is where the major thoughts will come, and I think we have already described about that. So we know very well. So let's move on. So this is again about invasive lymph node research. So I think we'll involve the medical oncologist also and the radiation oncologist. So radiation, some specific questions I have later. So maybe as a medical oncologist, because most of them will be meeting the pulmonologist pair of the medical oncologist. And I will start with Dr. Rekha Bansal. What are your thoughts about this diagnostic algorithm, or how much we are able to follow this?
So, sir, first of all, patients presenting in this early stage is very less. Most of the patients are in metastatic. But in case we do pick the patient in stage 3, then if the PET scan is not showing any lymph nodes, then we plan a EBUS. And if the PET scan is already showing a bulky N2, then probably after the MDT discussion, patient will go for chemo radiation therapy, sir.
So I think she's just reflecting what Dr. Sadish Pawar also told. So Dr. Sadik, I will ask you here, Dr. Sadik.
Yes, I agree more or less on the same. But
yeah, same thing. Yeah,
criteria is it a peripheral lesion or a central lesion? Peripheral small lesions without hilar lymphadenopathy, you can take, if the PET is negative, you can skip an EBUS.
Yes.
But if a peripheral lesion hilar node is positive and there's any suspicion in the PET, it's better to confirm with an EBUS.
Yeah, Dr. Dattatreya gave an interesting thing about T3 lesions, the PET avidity. That was an important point which he told. So, Dr. Rajiv, you are from Kidwai. So, what are the thoughts about this PET avidity? Is it really an important thing?
Most of the time, our patients will get the PET if you are planning for CTRT, curative intention. So, we do go with that. I agree with it.
Yeah, okay. Dr. Sadish, again back to you. This that I don't know whether you noticed that about the PET avidity and the what's that, the chance of medicine involved. Do you have any thoughts about that? Where you really look at the avidity of the lesion?
Yes, we look at the avidity of the lesion, but then especially for the mediastinum, if we have any doubt, like say for example, there is no uptake in the mediastinum, yes, definitely we should go for EBUS as we were discussing earlier. Yeah. But if there is uptake and you still have a doubt that whether this can be tuberculosis, I think that is where the whole management changes in our country at least. We should be careful in these settings. The most of the times what happens is these cases, even they present with cervical lymphadenopathy, you do a biopsy and turns out to be a tuberculosis.
That's also an issue. And again, this VATS techniques are becoming more important nowadays because previously people used to come with large thoracotomy scars. So what are your thoughts about that in a stage 3 disease or in MD?
Stage 3 disease, where if it is very close to the centralized lesions, close to the mediastinum, it really becomes difficult on VATS to dissect there because they are very close to the vessels and the bronchus. But definitely peripheral lesions are easier to dissect, and VATS definitely is preferable over an open approach.
Because again, all of us will have seen patients with thoracotomy coming back to us for years together with a pain there. So I think with VATS becoming more common, that can go. So I think this N1, N2, N3 things standard already we have seen that. And you already told about the factors which we talk about this one. So anyway, so this patient had a T4 entry disease, so no doubt there. So the initial plan was for paclitaxel carboplatin. So the pacli was given on a weekly basis, carbo on a 3-weekly basis. So it was a huge lesion. So neoadjuvant was used there. So any comments from Dr. Neeti Tandon about this neoadjuvant approach chemotherapy?
So the only other thing was that the patient had TTF1 positive adenocarcinomas. Yeah. So I would have chosen a pemetrexed carboplatin based regimen over this regimen.
Yeah. So what are the thoughts about the other medical, Dr. Rekha, about this, about the regimen? You have thoughts?
Sir, I think I would directly go for CTRT rather than neoadjuvant approach here.
Yeah, but this was a T4 and 3, it was 8 centimeter lesion. So whether Dr. Pragna, you have any concerns on the radiant side?
I would prefer going for upfront chemoradiation rather than neoadjuvant. We consider neoadjuvant when we think that the lung doses in radiation may not be achieved. Lung constraints or esophageal constraints may not be achieved with the bulky disease. The problem here is, I think, the N3 part, not the larger primary of the lung. So the mediastinal node, bulky mediastinal nodes may probably affect our lung doses, especially from the contralateral lung. So when we think that the lung doses cannot be achieved, lung constraints cannot be achieved, that's where we usually ask for neoadjuvant. But if it is if that is not a problem, I think upfront chemoradiation is a preferred approach for me in this patient.
And I think the RTOG trials and all were done maybe 20 years back, in which the toxicities were highlighted like 20 to 40%. Do we really see that with the newer techniques which we are using now?
No, sir, not unless we follow the constraints. We do see pneumonitis in our patients, maybe around 10 to 15% rates, but symptomatic pneumonitis requiring prolonged steroids, we don't see often if we are keeping our doses under the constraints.
Dr. Sadhvik, what are your comments about the initial chemo regimens anything Paclitaxel are okay or PEM-CARB only?
Sir, Paclitaxel is good enough. Only thing is non-squamous histology, PEM-CARB, there is a study saying it is equally efficacious and a bit more tolerable. That is the only thing, but you're not wrong starting off with the Paclitaxel because there's a lot of data with Paclitaxel. Cis-Eto I would avoid because of more toxicity concerns.
So the patient had a severe hypersensitivity factor, so we had to give Paclitaxel, and that's a different thing. Anyway, we hope that will be same. So completed 3 cycles of chemo. The follow-up PET was done, which showed a partial response to therapy. So somehow this patient was given neoadjuvant. Then we went to RT. So RT, the dose and other things comments from Dr. Prajna.
Yeah, sir. He received 66, but we usually follow 60 in our center. But 60 to 66, any dose is fine for the patient. And it should be preferably IGRT in lung, especially with the moving target. And also IGRT helps us in reducing the margins around the tumor so that the normal tissue lung doses can be reduced with this treatment. I agree with the treatment.
So this is again a sequential versus concurrent. I think at least a couple of the panelists today are favoring a concurrent regimen because all of us are aware of the importance of giving a concurrent therapy upfront. So Dr. Rajiv, your patients coming to, are you really able to give concurrent or do you have problems?
Yeah, I do agree with the other panelists, but most of the time the sequential CTRT is preferred or given the option from the radiation oncologist because of the not all T4, the T4 involving cardia or major vessels, they could not reach the complete, they cannot give the complete dose. So in those cases, they prefer sequential, even though the sequential is not matching the concurrent. But in those cases, we prefer sequential RT. That is what I feel. So most of the time, it is a call from the radiation oncologist rather than from the medical oncologist.
Again, we have to see on a patient by patient basis. The center all these things will matter when we discuss. So again. So I think we touched upon these points. So the patient received some radiation pneumonitis, which we can expect with such a huge tumors, and like Dr. Prajna, 10 to 15% can have despite all the stringent plannings which they could do. But fortunately, all of them respond to steroids also. After that, almost a month, that's what commonly happens on a tapering dose of steroids, the radiation pneumonitis. So this is about consolidation chemotherapy. So again, back to the medical oncology team, each can have their own thoughts about this, the various regimens, whether they like to give it or not, starting from Dr. Nikita.
So if I am not using consolidation immunotherapy, then I would prefer to give 4 cycles. At times when the so 2 concurrent with radiation and 2 after the radiation. At times when the patient is not fit to receive, I use a weekly regimen of paclitaxel carboplatin while the patient is undergoing radiation, which is changed to a 3 weekly regimen after it is completed.
Yeah, I think that reflects what most of us will practically do also. I think Dr. Rekha was wanting to use pemetrexed. So what will be you prefer? So how will you?
Sir, after CTRT, first of all, we have enough evidence, the pooled analysis, which showed that there was no survival advantage with any, consolidation chemotherapy, unless again post CTRT, probably unless it's a young patient who cannot afford durvalumab, I would consider, sir. Otherwise, maybe
because if the patient can get durvalumab, that's fine. But majority may not have. So, and again, it will be huge tumors. And do you really feel that the systemic dose which they have received is enough with concurrent only? That's right. That will be the issues.
So, unless weekly, sir, they had recommended 2 more complete cycles. Only if weekly doses were used during the concurrent radiation, sir.
The only thing I would like to add is I prefer to avoid the use of growth factors while the patient is receiving concurrent radiation therapy, because we have evidence stating that the risk of radiation esophagitis and pneumonitis increase. So a weekly regimen versus a sequential regimen.
Yeah, that's a very important. Dr. Sadiq, your thoughts on consolidation? You prefer regimen you have?
I mostly practice weekly paclitaxel, and then after that, following the weekly regimen, then 2 consolidation with 3 weekly is what I routinely practice.
And Dr. Prajna, I think RT-wise, the dose you already told, I think there is just one thing about 60 versus 74 gray of RT. So
No,
any
sir.
thoughts? Yeah.
No, 60. We limit to 60. Higher than 60, there is no evidence to continue beyond 60 in any of the trials. In fact, the higher dose might probably be inferior because of the toxicity.
Yes, because hazard ratio seems more than 1 when you divide.
Yes.
And even about targeted therapy, any Dr. Rajiv, targeted consolidation, placebo, cetuximab, all are shown to be.
No, we are not practicing all those things. So whenever patient is affordable for Durva, we give. Otherwise, yes.
So in that setting, that's why the immunotherapy is coming in, because in this case, the speaker was telling you the horse has bolted, but in our case, it seems like almost like an elephant, because it's a huge tumor sitting there. So we know it is going to come back fast, so we have to think of other. So PACIFIC trial, we have again and again told about that, so I'm not going to repeat that. All of us are aware of this. So this is about the PACIFIC R. I think the same slides which we saw before. So maintenance durvalumab therapy. What is the experience from the panelist? That's what I would like to know. Anybody can answer this? Theoretical and practically experiences. Dr. Dekha?
So theoretically, the 1500 mg once a monthly dose sounds really nice, but so far I have never been able to use durvalumab in any patient, sir.
Sir, I currently have 2 patients on durvalumab. I use the 10 mg per kg dose, 2 weekly regimen. And the one is an elderly patient. I couldn't start that based on the trial criteria. They started within 6 weeks. But one patient I couldn't start before 6 weeks, but he's still doing good on durvalumab. The other patient I could start in 3 weeks. So both of them are still on durvalumab and are in remission.
So as of now, the indication is maintenance therapy who have an unresectable stage 3 and who have no progress on platinum-based doublet chemoradiotherapy. So, so this is again about induction chemotherapy. Again, I think practically, even in a trial setting, almost more than 25% had received induction chemotherapy prior to surgery. So there was around 711 patients, and 26% had received. And in the case of question, the patient received NACT prior to CRT, and I think we discussed about the reasons. So NACT prior to CRT. The baseline characteristics about durva and placebo well balanced and all. So I think EGFR mutation is one area. I think Professor also told about this, that we'll be really tempted to give, even they are not resected. We may be tempted to use them for our patients. So, so Dr. Rajiv, so do you do EGFR for all your stage 3s nowadays? Even though they're curative?
Not for all. Wherever the tissue is available, we are doing it. Before that, I want to answer that immunotherapy experience. I was a part of PACIFIC 2 and PACIFIC 5. But most of the time, almost 10 plus cases we recruited. So most of the time, the selection of cases will be the other thing, important. So bad lung because of any disease or pre-existing disease or radiation pneumonitis, they doesn't do well. Otherwise, most of them, they tolerate nicely. Durva, coming to the Durva. But coming to the markers, wherever feasible, we do the EGFR, all-CRAS, all 3 we have in nose. But most of the time, the problem is with the tissue. So, but we are not going with the marker, but we treat as a standard guidelines.
Because nowadays we have this temptation to give their EGFR positive, whether to give them later, because we know durvalumab, most of our patients cannot
Some
be
subset analysis also they show molecular driven. They doesn't do well with immunotherapy, but still it is not a mature or good data to go with that. But we have to wait for the LARA data to come out. So we can practice that.
I think in the trial also, specific trial, this analysis also, they had the EGFR mutation status on maybe 70% of the patients, and
Yes,
in
yes.
them, just 10% were positive. So
Yes,
maybe
yes.
this is a predominantly EGFR negative group, and I think
Yes.
some reason stage 3, our EGFR positivity is also not that high. So that's fine. It makes job easier. So this is randomization when they did and all. I think we'll skip this. So this already we know about the how well the trials fared, and the speaker of inverted sclerosis telling that we are seems to be probably curing some. So maybe they're waiting for them to be long-term survivors, although even 33% are curing. Right. So it's the first and only approved IO to show sustained and durable PFS benefit at 5 years. Almost 40% were alive at 5 years. So that's a and across all subgroups, as already alluded to, it has shown an advantage. PDL1 expression also is there. They have analyzed, but PDL1 is a big question mark nowadays. So just one comments and about what are your first impression on these trials. So maybe we can start with Dr. Sadri. First impression on the ASCO 2021 update of the 5-year oral survival data. What considers to well? I think all of us agree. I won't ask because all of us agree it's a good drug. Is there any other points? No.
Yes, sir. It is definitely a good drug and it's a practice-changing trial.
So
Usually, yes.
So right time for counseling for patients. So that is a major problem. The start of Dr. Reggie was fortunate to be in a trial. So at starting is definitely the best thing. Post completion of CRP. So I think that is a major problem. Yeah, when we do scans at that time, there will be some residue remaining there. So what is thought? What are thoughts about that? Whether that will make a practical, whether you will talk about Durva at that point, like they responded excellently. So, okay, we'll wait if there is something remaining there, because after RT, we can't do a PET at 6 weeks, it won't show us anything. So, CT shows a mass is remaining there. So, Dr. Rekha, do you feel that if everything is gone, that is good, or anything is there about the response to chemo radiation at 6 weeks? Whether that impacts the way you speak to the patient about?
No, sir. So as long as I would like to counsel at the beginning only, and as long as there is no progression, we give durvalumab. So we counsel that if there is progression, we might not give, but if there is good response also, we will consolidate with durvalumab. Sir.
And Dr. Pragna, because chemo RT, you would have been following the patients. So what do you think happens to them? Because some masses will be remaining. So just your thoughts on that.
So complete responses we are not seeing in all patients, sir, especially around probably 50% of the patients we are seeing complete response at the first follow. Rest others we do counsel for adjuvant consultation to durvalumab. We send to medical oncologist to counsel for that.
Just the one point is, if they're in complete response, you feel that you can.
No, if the patient is affordable, yes, any response, as long as there is no progression, we are counseling for durvalumab. But if the patient is not affordable, we may have to consider it. But if there is residual, definitely we will be pushing.
Residual may be there because like what we are seeing nowadays, 80% of our patients are adenocarcinomas nowadays.
Yes.
And it's unlike squamous, which may just go away with chemo RT, adenos will remain, isn't it? That's a practical issue which all of us are facing. So with more and more of adenocarcinomas coming in, all of us are seeing more of residual masses. Any thoughts on this about from Dr. Nithya and Dr. Sadhu? The response and
so, sir, I counsel the patients upfront before starting CTRT about the use of Durva, and before doing the scan only. I tell that the intent of the scan is to just ensure that there is some response and there is no progression, and that unless there is a progression, that will not change our plan of giving Durva.
Rajiv, you would have seen 10 patients. So what really happened?
Yeah. See, according to the trial, any response we can give unless it is progressing. Yes. And the trial, the Pacific 5 allowed 3 cycles of chemotherapy. Even if it is not completed during the RT period, you can give after the thing. And if you see the real world data also, they have recruited beyond 6 weeks. So even in that subset also, they have a benefit. So I feel wherever possible and feasible, we can go with the Durva consolidation for all the patients, irrespective of the response. And as other speaker mentioning 50% CR, we don't see that much CR complete response. And it is difficult also to histopathologically prove at that situation or a scenario. I feel any response, unless there is a progression, we can go with Durva maintenance.
So just we'll rush through what happened now. Anyway, patients planned for Durva. So practically what happens up to 80 days after CTRT was when we gave that. And after that, there was a good therapeutic response and there is a reduction. FDG ability was coming down. So this again what we see practically. It may be still remain there. This is a frustrating thing with adenocarcinomas. It just doesn't go away. It remains there and it keeps on having some avidity. But then we tell the patient avidity is coming down. Good. So that's a good therapeutic response. That's what we counsel. And so what's this? Okay. We already alluded to. So we had a partial response to therapy and all 26 cycles were complete. And the last patient was admitted for a 27th cycle of immunotherapy, and patient continues to be in remission afterwards. We could complete the treatment. So this is a curative intent which we are talking of nowadays for a stage 3, 5-year-old survival almost doubling from 15-25% to 42%. So the key takeaways, I think, from today's all discussions were that MDT approach definitely gives the best outcomes. How to plan the MDT, I think we have to be more technically adept nowadays. CCRT definitely gives a better outcome, and radiation with although the traditional trials painted a bad picture, with the newer techniques, we may be able to go ahead with a lesser toxicity profile. And Durva is definitely the first and only approved immuno to demonstrate a 5-year OS and PFS benefit. Consolidation doesn't improve outcomes. Also, practically we may do, particularly for patients who are not able to afford immunotherapy. And Durva, definitely all of us agree that should be considered a treatment option in all unresectable stage 3 patients who don't progress on CTRT. So the response assessment, definitely we may not be able to make, and that may not be an ideal guide also to decide about Durva. And one important thing is that it improves outcomes across all subgroups, irrespective of PD-L1 status. Although PD-L1 less than 1 OS, there was some issue, but irrespective of all, it improves the survival or EGFR status. So these are the main takeaways from today's discussion. I think any other quick comments from one comments from the panelists, starting from the surgeon, Dr. Satish.
You, especially in 3A, you have to super select your patients and decide upfront like what would be your treatment plan. If you are considering surgery in your treatment plan, so whether you want to give neoadjuvant chemotherapy or give neoadjuvant chemo radiation, so most surgeons would prefer neoadjuvant chemotherapy because of the post-op morbidity and mortality. So you have to say, for example, you plan for neoadjuvant chemo radiation, you have to limit your doses so that it becomes easier for us to resect later. And those patients, definitely, if there is a mass where predominantly you see necrosis on your CT scan or a PET, then surgery will be preferable modality of treatment over CTRT, because these patients do not respond to chemoradiation particularly. So this thing has to be kept in mind while planning your treatment plan as such. And single station N2 disease surgery would be preferable with good overall survival over CTRT. So these are the two things I would like to put it.
Thanks for those practical points. Dr. Pratna, sir.
Dr. Arun, can I ask a question?
Yeah, please.
Yeah. What is the role of surgery after post CTRT? Can the surgical like?
Satish?
Yeah. So that's what I'm trying to tell, sir. The role of if the patient understands that there is associated morbidity and significant morbidity and mortality, and you have to super select your patients. You have to select those patients who have good pulmonary reserve after chemo radiation, And the one thing is, if you feel that the patient will land up in pneumonectomy, it's a straight away no. So if you feel that you can get away with lobectomy, yes, you can still try for. But then that's what, if the radiation oncologist has planned it before as a neoadjuvant chemoradiation dose, then it would be it is easier for the surgeon to resect.
So I think the main idea is that each patient we have to closely monitor, select and we have to make the judicious use of all the 3 modalities which are given. So I think we have exceeded the time limit. So back to the organizer. So thanks to the panelists for the good discussion.
Thank you.
I would like to thank Dr. Arun sir for an excellent panel discussion, and I would like to thank Dr. Rajiv sir, who's my mentor and who's guided me during my residency. Thank you, sir. Thank you for your time. All the panelists for having a wonderful panel discussion. So I would now like to invite Dr. Prasad Ishwaran, Senior Consultant Medical Oncologist from MEOT International Hospitals, Chennai, who will be talking about unmet need in ALK positive lung cancers. Over to you, Dr. Prasad.
Yeah, thank you so much. Thanks, Dr. Deepak, for the kind introduction. I hope my screen is visible to you.
Yeah, it's visible.
Right, thank you. So I'll be having a short and a quick discussion about what we do have achieved, what we had treated, and how are we going to manage with the newer drugs in the management of metastatic non-small cell lung carcinomas, which are ALK positive. So a brief introduction. I mean, everyone knows about this. The cancer incidences are increasing and the mortality is also increasing. But thanks to all the new drugs that are coming up, and we are able to have some sort of a control over the mortality in the recent years, with more and more of the availability of the diagnosis, the understanding of the molecular pathology, newer drugs. And right now I'll confine my talks only to the specific ALK gene. So we know that in real world practice, ALK is increasingly becoming more and more common, with the the NGS panels and other common and uncommon mutations that are happening. So this is one study which was published from India, which shows that we have somewhere around 1 to 10% percentage of all the NSCLCs which would express this ALK mutation. One important thing about this ALK mutation is that the overall survival, unlike the other aggressive types or the wild or mutant types, ALK positive does have a longer survival. So patients, even with the first line treatment with crizotinib, had a median overall survival of nearly about 6 years. That's quite impressive. So researchers had worked on more, making this as one of the chronic diseases. So what exactly makes this ALK positive a separate subtype of lung carcinoma? So it is specifically more common in the minimal or the non-smokers, mostly in the adenocarcinoma, younger age group, and it does not have any concurrent driver mutations. So they are specifically solitary ALK mutation positive diseases, and clinically, we do see nearly about 30% of these ALK patients presenting with brain metastasis, but very rare, 3 to 5% of total unselected patients of non-small cell carcinoma. Sometimes in patients who have EGFR wild type, it constitutes nearly about 33%. So there are increase in the understanding, the increase in the usage of all these molecular studies. So we started with the Sanger sequencing thanks to the olden days. Now we had IHCs to check for ALK positivity, RT-PCR, FISH, multiplex mutation texting, multiplex sizing assays, or next generation sequencing. All these modalities had come to find out and help us all these targetable mutations in non-small cell lung carcinoma. So once we know that we do have some tests, we are now looking at the targets. So nearly about, just like in small cell lung carcinomas, where we nearly did not have anything other than cisplatin etoposide for nearly about 30 years. So till about 2007, when the first EML4 ALK translocation was identified, the first drug came up in another 5 years in 2012, crizotinib. In India, we started using crizotinib somewhere around that time on a compassionate basis, and subsequently it was available for our patients. In 2015, we did have the other drugs approved in the second generation. In the recent years, we started having all these new drugs in our first line indications itself. So in 2021, the US FDA had approved lorlatinib in the frontline setting, which is the recent third generation molecule. So what is very specific about this ALK positive is that it is more common in the younger age group. So we need to really do something to improve their overall survival, non-smokers, adenocarcinoma. And as of now, we do have 5 drugs to treat this specific subgroup. So what exactly are we looking at with the use of the second or the third generation over the previous generation is that the potency against ALK, the overall response rates, the survival rates are much better with the use of the third generation drugs. Activity is high, as well as a better CNS penetration. So when we look at the first generation molecule, crizotinib, which was then compared with the chemotherapy, we could see that patients who had all positive disease had a better progression-free survival of about 10.9 months versus 7 months when compared with crizotinib versus chemotherapy. So when we look at the overall survival, we did see that the curves had started to separate, but they were not statistically significant. So we were a little comfortable that we did have one drug, but it was not quite impressive. So next comes the ceritinib. Again, PFS was much better. We did have a progression-free survival of about 16 months versus 8 months. Again, coming to the OS data, it was statistically 0.056, kind of becoming more and more significant, but we did have a second drug to use in our patients who have ALK positivity. Then came the explosion. We did have the newer drugs, alectinib, which was compared with the standard crizotinib. So we did have one standard drug with the experimental arm, and we know that alectinib did much better than crizotinib. So crizotinib, the PFS was 10.9 months. With alectinib, we had about 34.8 months. So nearly about 3 times more than what we could achieve with the first generation molecule. So this is a slide which gives a comparison of all the first and the second generation ALK positive molecules. We did have a progression-free survival of nearly about 7 to 11 months. So nothing more than 12 months what we could achieve with the first and the second generation molecule. Coming to the real world data. So real world data was it was a study based on the TMH in which nearly about 41 patients were followed up with for about 16 months, and brain metastasis in this particular subgroup was about 60%. The clinical response rates were about 73%. Median PFS was an impressive 16 months, and the median overall survival was just less than about 24 months. We started understanding more and more about this ALK. We got more and more mutations positive, and with more and more mutations, we got more and more confused also. But
so sorry for intervening. You have 2 minutes left to conclude.
Yes. So with the understanding and with the availability of newer drugs, now we are looking at the 4th generation molecule, which is gilteritinib, which can overcome lorlatinib resistance in ALK rearranged cancers. So as of now, we did have a Cochrane database analysis which had said that any of the first line molecules with alectinib, brigatinib, or lorlatinib would be the preferred drug. Now we are looking at the usage of the first line ensartinib in the first line setup as well. So what is the use of using a pan inhibitory molecule? Because we know that being a 3rd generation molecule, lorlatinib is able to suppress the emergence of single ALK resistant mutations, and upfront use of these recent molecules will suppress or significantly delay the disease progression. So I'll have a quick discussion about the CROWN study in which the patients were randomized between lorlatinib versus crizotinib. PFS, again, when we look at the data, the 1-year data is very impressive, 39 versus 78 months. The progression-free survival by the investigator again reflected the same. Intracranial responses were much better, showing that the drug is able to have a better CNS penetration and also have a better activity in the patients who have brain metastasis. So on overall comparison, we did have all these 4 molecules as the first line preferred molecules in patients who have ALK positive cancer. And this had been reflected in the NCCN guidelines as well. So initially we started with only crizotinib. Now we do have 5 drugs which are category 1 recommendation by the NCCN. So how do we choose a drug? How do we choose a drug? It all depends upon the disease factor and the patient factor. We know that we need to choose the patient, and as far as the availability, the CNS metastasis, and the rapidity that we need to get the response, we will be able to choose this one of these 5 drugs. So none of the discussion is complete without discussing the complications of a drug. Of course, for lack of time, I'm skipping this slide, but we need to understand with each drug, we did have a different type of side effect with these molecules. Immunotherapy completes the talk for any non-small cell lung carcinomas, but specifically in ALK positive, whenever there is a driver mutation positive, immunotherapy agents do not give any additional benefit. So this is my last slide. So this gives an overall profile of what we are looking at as a progression-free survival when we use sequential drugs or when we straight away start using the recent molecule. So when we use a sequential drug, we kind of stop short somewhere around 22 to 25 months. But when we start using the 3rd generation molecule like lorlatinib, the drug like alectinib, we are looking at somewhere around 40 months of progression-free survival with alectinib followed by lorlatinib. And if lorlatinib per se is used in the 3rd generation recent molecule in the first line setting, as of now, we are looking at somewhere around 40 months right away. So probably we are now spoiled for choices, but we need to choose the right drug for the right patient and give them the best hope of survival. Thank you so much for your kind listening.
Thank you, Dr. Prasad Easwaran. So I'll be giving the next talk, and yeah.
Thank you, Dr. Deepak.
Thank you. Thank you. So quickly, I'll try to complete my talk in view of the time we have. So yeah. So I think my screen is visible, and I'll be talking about the role of newer advancements in early lung cancer in regard with therapeutic agents. So as we all know, we have around 15 to 20% of our lung cancer patients in a practice who are operable. And once you see the number of patients in stage 1 and stage 2, I think this data might be a little surprising, but this comes from Dr. Murali and team's publication, which say around 5% of our patients belong to stage 1 and stage 2. And this is what we've seen even in our data when we've retrospectively evaluated our data. Only 5% of the patients present in stage 1 or stage 2 disease. And what we also know is patients from stage 1B to stage 3A have a dismal prognosis, and the benefit of chemotherapy is only 5% improvement at 5 years. So the best we have is chemotherapy in the adjuvant setting, and the advantage of adding adjuvant chemotherapy is only 5%. How do we improve on this 5% is going to be the talk. And as we all know, once the ADAURA data has come out, we all now try to introduce EGFR targeted therapies in patients with stage 1B to stage 3 if they harbor EGFR mutation. We are actively looking forward for the Alchemist data, particularly for the ALK positive subset where they've used crizotinib. And now coming to the immunotherapeutic benefits. Can immunotherapy add on to chemotherapy in this setting is going to be the talk. So we have our adjuvant immunotherapy trials. Most have switch maintenance with immunotherapy. We have data from the IMpower 010, which were published in the NEJM and got a recent US FDA approval. And we have the PEARLS data, which was, there was a news press release regarding the data of pembrolizumab, which I'll be covering in this talk. So coming to the IMpower 010 trial, here patients with stage 1B to stage 3A, as per the AJCC stage 7, the 7th edition, were included patients post chemotherapy with cisplatin, and the tablet could include either pemetrexed, gemcitabine, docetaxel, or vinorelbine. 1 to 4 cycles, at least patients were supposed to receive 1 cycle of the chemotherapy, and later were randomized to atezolizumab and best supportive care. So the randomization happened post-adjuvant treatment to either atezolizumab or best supportive care, and no crossover was allowed. The primary endpoints in the study were investigator-assessed disease-free survival, and a hierarchical statistical testing was used. So first, disease-free survival in patients harboring PD-L1 levels more than 1%. This was assessed by the Ventana SP263. If the patient's DFS boundary was met, later DFS was evaluated in all patients from stage 2 to stage 3A. And if this endpoint was met, and then a DFS in the intent to treat population that included even stage 1B along with stage 2 and stage 3 was evaluated. And once this disease-free endpoint was met, an overall survival analysis was conducted. So around 65% of the patients had non-squamous histology, and PD-L1 positivity was around 50 to 55%. Mediastinal lymph node dissection was conducted in 80% of the patients, and around 75% of the patients had lobectomy, which more or less resembles our clinical practice. So now coming to the results of the study, the primary endpoint in the first subset was reached. That is, patients having PD-L1 expression more than or equal to 1% in stage 2 to stage 3A, and a DFS advantage was seen. It was the median DFS was not reached in the atezolizumab arm, and it was 35 months in the best supportive care group. And a 34% risk reduction of disease progression was seen. Now coming to all randomized patients, irrespective of the PD-L1 levels, the benefit was still persistent, and a median DFS was 42 months versus 35 months. A 7-month improvement in the DFS was seen with the addition of atezolizumab. Now, surprisingly, when stage 1B was included, that is the intention to treat population was analyzed, though the advantage was present, it didn't reach the DFS, pre-specified DFS, or the DFS significant boundary was not crossed. Hence, the study is, we need to wait for the overall survival data to be published. But as per the statistical requirement, the OS analysis is, we would not move forward with the OS analysis. Now coming to the IMpower data in the first subgroup, that is PD-L1 more than 1% in stage 2 to stage 3A, consistent benefit was seen in all subgroups except for the ALK positive subgroup. So just as a reminder, this study included patients having EGFR and ALK mutations, unlike the neoadjuvant CheckMate 816 study. And now coming to the patients, the all-comer patients in stage 2 to stage 3A, no benefit was seen in patients who had, the predominant benefit was because of the patients having who had PD-L1 levels more than 50%, maximum benefit was seen, rather than patients having PD-L1 less than 1%. And one interesting thing was ctDNA analysis. This was done in most of the patients. ctDNA analysis was seen, and patients who had ctDNA negative at the end of chemotherapy had a significant improvement in survival, irrespective of addition of atezolizumab or no addition of atezolizumab. But if the patient was on best supportive care and had persistent ctDNA detection of the tumor persistence, these had the worst possible outcomes. So at least in patients, this probably could help us plan further clinical trials, that in patients who had PD-L1, who had ctDNA negative at the end of adjuvant chemotherapy, can be further enhanced by giving immunotherapy. A minimal increase in side effects was seen, a 10% increase in side effects was seen. Now coming to the OS, at interim DFS analysis, the OS was premature, and we are awaiting for the mature OS data in the study. Following which, an FDA approval was given in patients who had PD-L1 expression of more than or equal to 1% and stage 2 to stage 3A. This is the latest update. This was in this year, 2022, where the Keynote 091 Pulse data, the MSD group have released a press release saying that the DFS benefit was present and across patients 1B to 3A, but in patients having TPS more than 50%, the pre-specified DFS endpoint was not met, and the study is still yet to release and yet to be discussed in one of the meetings, or is yet to be published. Now coming to neoadjuvant IO trials, see, though the rapid US FDA approvals have been seen in lung cancer, but in spite of the CheckMate 816, we do not have a US FDA approval in this setting. And though the phase 2 studies have shown promising results, we are yet to have a phase 3 trial based on which an approval has to be given. Except for the CheckMate 816, we do not have published phase 3. Even the CheckMate 816 is not yet published. We do not have results in the phase 3 setting. Now coming to why do we even need neoadjuvant therapy in NSCLC? neoadjuvant immuno versus neoadjuvant immunochemo. There are multiple questions in this domain. The benefit predominantly is to see that the compliance or the benefit of adjuvant chemotherapy is given a little and more patients end up on chemotherapy. But the downside is the most definitive treatment, that is surgery, is not possible in few patients. And I'll be discussing that in further trials. So benefit of preoperative chemotherapy is 5% advantage at 5 years, but this was compared to patients who've not received any adjuvant chemotherapy. So rather than not receiving any treatment, some chemotherapy either before or after surgery is mandatory in lung cancer. Now,
sorry for intervening. You have 2 minutes left to conclude.
Now, coming to the initial data which got published in NEJM, which showed that 2 cycles of nivolumab, there is 45% major pathological response and 15% pathological complete response in 21 patients, which was initially published in 2018 in NEJM. There were multiple trials which, based on this, were evaluating the benefit of single agent immunotherapy, but this is the best to date. And the PRINCEP study showed that with single agent atezolizumab, single dose, no pathological complete responses were seen. And again, biomarkers have not really shown promising benefit. So single agent immunotherapy, you're putting the patient at risk, and you might eventually have some patients who progress on single agent immunotherapy. That's where combination of immuno and chemotherapy have shown significant improved results. The NADIM study per se has shown that 85% patients had major pathological response and around 70% of the patients had pathological complete response. This was a phase 2 single arm study where nivolumab was combined with paclitaxel. Later, the Checkmate 816, which randomized patients between Nivo-chemo versus chemo, there was no upfront surgery followed by adjuvant chemo in the study. There was Nivo-Ipi, another study. The arm got closed early based on the NADIM data. So it was Nivo-chemo, which was taken further in this analysis. 50% of the patients had PD-L1 more than 1%. Here, I would like to highlight that around 15 to 20% of the patients, the surgery gets delayed. So you're denying surgery in around 15 to 20% of the patients. And the phase 3 study showed that the pathological complete responses are only 24%, not as high as 70%. And the major pathological responses are only 37%, not as high as 84%, as we've seen in the NADIM study. So eventually, your pathological complete responses with chemo-immuno combination are somewhere around 50 to 80%. Pathological complete response are 18 to 60%, but you delay surgery or deny surgery in around 15 to 20% of the patients. Now, you do not have an ideal biomarker, and what immunotherapeutic agent is still not clear, at least today's date. If you want to use neoadjuvant therapy, probably nivolumab is the best agent. When do we do surgery? It varied across studies from as early as 4 to 12 weeks. In the Checkmate 816, it was after 6 weeks. And you have to remember that though the patients have pathological complete response, these are not shown radiologically. So radiological response is not if the patient does not have radiological response, does not mean the patient has not responded to neoadjuvant therapy. Now, pathological response, there are multiple criteria. I would not go into the detail of it. Using ctDNA, as I've told earlier, probably ctDNA might be a modality to assess residual disease, and based on that, escalation of therapy can be done. Thank you. So now I would like to invite Dr. Unni S. Pillai to talk about newer updates in limited stage SCLC. We've heard about the recent updates in extensive stage SCLC. Limited stage SCLC is now the thing. And Dr. Unni S. Pillai is a consultant medical oncologist from Caritas Hospitals, Kottayam. Over to you, Dr. Pillai.
Thank you so much for a wonderful introduction. I shall share my screen. Is my screen visible? Is my screen visible?
Yes, sir. Yes, sir. Yes, sir.
So my topic of presentation is newer update in limited stage small cell lung cancer. As you all know, it's around 10% of all lung cancers is small cell lung cancer, and it's very, very difficult disease to treat. Your 5-year survival for SCLC is approximately 6%. And it's one of the very recalcitrant, very resistant tumor to treat. And you have a, modified VA lung group staging system for SCLC, where you have limited stage or extensive stage. I'm not going into the detail. SCLC is predominantly diagnosed in extensive stage. That means around 60 to 70% of them are extensive stage, and only 1/3 or 30 or 35% are in limited stage. And the majority of, or almost all the small cell lung cancers are due to smoking. This we have seen. The common recommendation or the standard treatment approach for the small cell lung cancer, whether they are limited stage or extensive stage, is to go ahead with chemotherapy. And at the end of the chemotherapy, you consolidate with the radiation treatment. So and there is this very small role for surgery. If you have a T1 or T2 tumor and you have a pathologically staged mediastinum, which is negative, then in this situation, you can go ahead and do a lobectomy and mediastinal lymph node dissection, and then you can go ahead with the adjuvant therapy. In all other situations, there is no surgery. Your treatment is basically chemotherapy followed by radiotherapy. And most of the patients, whether they are limited stage or extensive stage, you will get excellent response to therapy. But the problem is we cannot sustain that response for a very long time. If you see 1 year overall survival, it's pretty nice, 40-50%. But if you see the 5-year survival down the lane, it's less than 10%. So almost all the tumor respond very well to treatment. You have a reasonably good 1 year overall survival, but you don't have a very good 5-year overall survival. Median progression-free survival is around 15 months for small cell limited stage lung cancer, and your median overall survival is hardly 20-25 months. And that we have made many advances since 1985. You have cisplatin etoposide in 1985. Then carboplatin came in 1999. Topotecan came a second line agent in 1998. And after that, not much big achievement. You have nivolumab as third line agent in 2018, and recently we have approval for atezolizumab and nivolumab in extensive stage small cell lung cancer. So we know the limited stage SCLC, the treatment is you evaluate the performance status. If you have very good performance status, then you give chemotherapy followed by concurrent chemoradiotherapy. That is the standard of care. And if you have a very frail old patient, or if your performance status is not good and that is not due to the SCLC per se, then you have to individualize the therapy. So this all things we know. We know that etoposide cisplatin or etoposide platinum is the best available chemotherapy agent, and giving concurrent chemotherapy, sequential chemotherapy, chemoradiotherapy, concurrent chemoradiotherapy could be will have some edge over sequential chemoradiotherapy. And again, OD versus BID radiation dose. Again, OD dose is superior to giving BID to accelerated fractionation. So, in spite of all these advantages, what we know that we have not made big advantages or big jump or quantum leap in the field of small cell lung cancer. So then, why immunotherapy in small cell lung cancer? You have multiple answers. One, you have multiple mutations in small cell lung cancer, but none of them are targetable. That's one issue. Second, even though you get very good response to chemotherapy, we are unable to sustain the response because most of the patients relapse over a short span of time. This is because of many reasons, and the rationale for combining immune checkpoint inhibitor with concurrent chemotherapy in small cell lung cancer are: once you use chemotherapy and there is excellent response to chemotherapy, a lot of neoantigens are formed. But the problem is that since there are PD-L1 overexpression, there is immune cell evasion. So there is no, the immune cells are not getting primed and immune response is not being formed. But when you use an immune checkpoint inhibitor, when you use an immune checkpoint inhibitor, here, what you can use is you can avoid this immune set evasion, and probably you can prolong the duration of response. The association of PD-L1 expression in small cell lung cancer, again, those tumors which express PD-L1 are having a better overall survival compared to those who are PD-L1 negative. And again, if you see the tumor mutation burden, small cell lung cancer is one tumor which is having a high tumor mutation burden. Because of all this reason, immunotherapy is a feasible option, and it makes sense to combine immunotherapy with chemotherapy in small cell lung cancer. And we have seen the results in a limited, extensive stage with the atezolizumab and durvalumab, which has made an impact. We have ongoing clinical trial. One is Adriatic trial and Stimuli. I'm coming to that in detail. In Adriatic, the patients with the limited stage small cell lung cancer no progression following first line chemotherapy. After CTRT, they will be randomized to either durvalumab plus tremelimumab, that is a PD-L1 plus a CTLA-4 inhibitor, or durvalumab plus placebo or placebo alone, for 4 cycles, followed by either durvalumab maintenance or placebo maintenance. And this trial is enrolling around 728 patients, and is expected to complete enrollment somewhere by the end of 2024. And you have a NRG LU005 trial. Again, it's a phase 2/3 trial. Here, we are combining atezolizumab with chemotherapy. Atezolizumab will be added from the second cycle of chemotherapy itself. And atezolizumab will become, it will be continued after the completion of radiotherapy also for a period of 1 year. This trial again is expected to complete enrollment in 2026 and is expected to give us the result in 2028. And we have the Stimuli trial, which has finished enrollment and is been published. Again, after chemotherapy and radiotherapy, patients were randomized to nivolumab plus ipilimumab into 4 cycles, followed by nivolumab maintenance for 12 months. And if you see the outcome, there is no difference. Ipi plus nivo versus observed placebo has not made a big impact. So it is a negative trial. And overview of published studies of immune checkpoint inhibitors in small cell lung cancer. Of that, we should put some effort to understand this CheckMate 032 trial. The CheckMate 32 trial, 032 trial, patients were at least who had progressive disease after at least 2 lines of therapy, including at least one prior platinum-based therapy, were randomized in 3:2 fashion into either nivolumab at 3 mg per kilogram every 2 weekly versus Ipi plus Nivo 1 and Ipi 3 every 3 weekly into 4 cycles, followed by nivolumab maintenance at 3 mg per kg. And again, you see the primary objective is objective response rate, and the secondary objective was overall survival, progression-free survival, and duration of response and safety. If you see the objective response rate, those who got Ipi plus Nivo, they were having better response compared to nivolumab alone. And if you see the overall survival, Ipi plus Nivo is superior to nivolumab alone. And you're going to get around 8 months median overall survival in someone who has progressed after at least 2 lines of therapy in small cell lung cancer. This is very impressive. And one more important aspect is someone who has some kind of response. The median duration of response is not reached. So not everybody is going to respond to our immunotherapy, but once they respond, majority of them, or at least I think a majority of them will have a durable and prolonged response over a period of around 18 to 20 months. If you follow them up, most of them are still continue to respond to therapy. And the response to nivolumab or ipilimumab is independent of our PD-L1 status. Whether they are PD-L1 positive or PD-L1 negative, even patients with PD-L1 negative do respond, and patients with PD-L1 positive, those patients, if you see the waterfall curve, on either side of the waterfall, and the upside and downside, you can see all the colors. So it is independent of the PD-L1 expression. So based on this data, nivolumab is approved as a third-line agent in small cell lung cancer. And again, CheckMate 331 trial, second-line nivolumab in patients with relapsed NSCLC. This is nivolumab versus topotecan. Again, you see there is not much difference. But if you see the graph very carefully, if you see this forest plot, those who have low disease burden, that is LDH, which is less than the upper limit of normal, those who have platinum refractory disease, and those who were having no liver metastasis, those patients are likely to do well with nivolumab compared to topotecan. So let me summarize. The SCLC is an aggressive tumor. Possibility of long-term disease-free survival is very small. Only 6% of or so are ultimately going to survive for more than or equal to 5 years. Most of them will relapse, irrespective of what kind of response you get with your chemotherapy or radiotherapy. The STIMULATE trial, that is EP plus nivo, after chemotherapy and radiotherapy was a failure. But ipilimumab plus nivolumab or nivolumab alone, and after 2 lines of prior chemotherapy, including one prior platinum, is a successful trial. We are awaiting the results of Adriatic and NRG-LU005 trial. CheckMate 32, that is nivolumab plus ipilimumab, is now a guideline recommended second line or third line option in SCLC, which we have already discussed. And PD-L1 expression testing does not appear to identify the benefit of SCLC. Again, from CheckMate 032 trial. With that, I conclude. Thank you.
So thanks a lot, Dr. Unni Pillai. And with this, we come to the conclusion of the lung cancer program today. I would like to thank the organizers, the Horizon team. And I would also like to thank AstraZeneca and Intas for sponsoring and for being a huge support. And thank you all. Thank you all. Have a great night. Good night, guys.
Thank you.
Thank you.
Thank you so much.